Welcome everybody to our July board. Before we begin, I just want to welcome Laura Roberts, who has replaced Jenny Jones. This is her first board meeting, and Laura, I think you've done a terrific job, by the way, in terms of taking over and pulling everything together. So thank you for that, and you're very welcome. And we've got a number of external contributors today, and obviously they'll introduce themselves later on, and they're very welcome, as well as our internal guests as well. I see Mandy there, and there'll be a few other Humber faces joining us during the course of our proceedings. So let's start. Apologies for absence. I don't think we have any apologies for absence. I think we've got a full house today. Declarations of interest. If there's anything on the agenda that causes a conflict, let me know. And also, if you have to update your declarations, please let Laura know, and she'll make sure that that happens. Anybody want to raise anything now in terms of conflict? No? Okay, thank you very much. Just also on the agenda for today, I'm going to swap item 16, which is the Humber and North Yorkshire Integrated Care System, which Alison would have been attending. Obviously, Michelle leads on that as well, with item 20, which involves Tracy Flanagan doing the 6-month review of staffing safety. That's partly because, as you can see on the agenda, 21-22 also involves Alison Flack. So we've swapped those two out, and Tracy is aware of that. And we'll look to have a break hopefully about 11:20 before continuing the agenda. So I think that is the only change. And of course, just in terms of the agenda, we've had an equality assurance report come in from Phil as well, from the subcommittee to the board, and that is on the agenda too, along with you will be aware we sent a part 2, I suppose, Finance and Investment Committee report, because I think thankfully our chairs have really done a really good turnaround from their committees to get these assurance reports to the board, and it's really appreciated their work and staff's work on doing that. Okay, without further then, minutes of the meeting held on the 29th of May, are they a correct record? And are they approved by the board? Thank you very much. Action log and matters arising from the minutes. Are there any that colleagues would like to raise? No? Okay then. In that case, I'm just double checking. I don't want to be too quick on this. No, I think that's fine. In that case, we can move on to item 5, which will be followed by item 6. And normally, as you know, we would have a staff patient story, but actually these two items reflect in some ways staff patient stories, and they are the voice of patients and the voice of staff. And we are going to start with a voice of our patients and in the Community Mental Health Survey, user survey of 2023. And we've got Emma Potts and Mandy Dawley, I think, with us today, who are going to guide us through this. You're very welcome. Army, did you want to say anything before it starts, or are you happy to go to them?
Yeah, no, happy to continue and to invite, to welcome Elaine and Acuvia. I think we have partnership with Acuvia, not only for Community Mental Health Survey, but also through our patient survey. And as you know, we take it very seriously.
Thank you very much.
So,
okay, over to Mandy and Elaine.
Okay, thank you. So Elaine's going to share a presentation of a summary of the highlights of the results from our 2023 survey. So I'll hand you over to Elaine.
Thanks, Mandy. Can everyone see those slides okay? Sharing?
Yes, that's brilliant.
Excellent. So we've got a short presentation and then time for questions at the end, if anyone wants to clarify anything. As you said, this is a review of the results of the 2023 Community Mental Health Survey of survey users. And just to make everyone aware of the methodology that was used this time, because there have been quite a few changes. So for the first time, it's been a mixed mode of online and paper questionnaires for the first time. And there was also a change in the fieldwork period. So this year we sampled survey users that were seen by the Trust in April and May. And then the survey was carried out between August and November last year. It's still the same sample. The only addition to the sample is that 16 and 17-year-olds seen by adult services have also been included for the first time. And there were quite a lot of changes to the questions this year. So you won't see any year-on-year comparisons because there's only very few questions that actually stayed the same. And even questions on the face of it that seem to stay the same. Those changes in the sampling period and in the methodology mean that those results aren't directly comparable year on year anyway. So what we have done is put in a benchmark to the average of all the trusts across the sector that we worked with. So that's all of the 53 mental health trusts and community interest companies that were involved in the survey this year. So you'll see their benchmark to compare yourselves to. So just to touch on the response rate that you achieved in this year's survey, there was a response rate of 18%. That is slightly lower than you have achieved in previous years. And one of the reasons for that is this change to mixed mode methodology. Unfortunately, only 30% of your responses came through the online survey, compared to about 50% of other trusts nationally. And one of the reasons for that was that SMS messages were sent as reminders, but we didn't have very many phone numbers for the sample that you provided to be able to prompt people to go and complete the survey online. So really having a review of the data that you hold about the service users and making sure you can contact them in that way is really important for next year. So throughout the survey, I'll refer to where you sit in the kind of ranking of trusts. So how we look at this is that a really good score is in the top 20% of trusts that we survey. There's the middle 60% and then the lowest 20%. So you can see that the majority of the questions that are scored fall in that middle 60% of trusts for yourselves. So that means you're very much in line with the rest of the sector, and there isn't too much to pull out as kind of really areas of concern. There's only one question which we'll come on to is about reviewing of medication that's in the bottom 20% of trusts, and 5 that are in the top 20, which I'll highlight as we go through. So we'll go through the questionnaire in order in a minute, but I think it's nice to start at the end with these. So these are your overall scores. So overall, how was the experience that service users had of using the trust? Again, your score is very slightly higher than the sector. So where it says all there, that's the average across all trusts in the sector, and the benchmark that we're going to use today. So you're very slightly higher than average, but you're in that middle 60% of trusts for that score. Again, for feeling treated with respect and dignity, a score of 78.9%, really good compared to others in the sector. So the first section of the questionnaire asks about the people's care and treatment, and particularly while they were waiting to start their treatment. And this is one that we flagged as a particular strength of yours. So you're in the top 20% of trusts for that first question, the support that people are being offered between being assessed and waiting to start their treatment, a score of 68.6%. Similarly, whether that support meets the needs of those service users, again, is higher than average. So quite a strength in that area before people start their treatment. It then goes on to ask about people's experiences of the mental health team over the last 12-month period. And these are all quite new questions, or kind of questions that have been phrased quite differently to how they were before. So people are generally quite positive about how much time they're getting to discuss their treatment and getting the help that they need from the mental health team. And again, one of the particular strengths is that the mental health team are considering the whole person and their whole life when they're making those assessments and discussing it with them. Also, we've seen that people don't necessarily have to repeat their mental health history because the professionals have all that information to hand, and that people, a really high score there, 78%, being treated with care and compassion. So sometimes there's room for improvement in all of these scores, but we're just trying to pull out where there's particular points of interest. Then moving on to their care, and these are again quite new questions for this year. The first one being, do you have a care plan? And it's a simple yes or no question that's asked to respondents. And we do see fairly low scores across the sector for this question. And you do lag behind that kind of sector average a little bit, down at 61.9% of people saying that they had a care plan. And what we reiterate here is that people think of that as the kind of physical bit of paper that is actually labelled at the top, your care plan. So it's really important that people are having that documentation, and that's kind of reflected in why the questionnaire has moved that way, away from questions such as who is arranging your care and kind of do you know what they're responsible for? It's about that kind of written documentation that people receive. Similarly, in question 16, in the last 12 months, have you had a care review meeting to discuss how your care is working? Only a score of 56% for that one. And again, that might be about the kind of communication and the labelling of that as an annual review of why service users are slightly confused of whether that's happened. Then finally, on do you feel in control of your care? Although that's not a particularly high score, again, that's one where you fall in the top 20% of trusts and compare quite favourably to the rest of the sector. So we then move on to questions about your treatment, and these are primarily questions about your medication. So people do feel like they're having discussions when they first start taking their medication, particularly about the purpose and the benefits, fairly high scores there. But then to question C and 21C and 21D, a lower score for people knowing what the side effects are, and particularly any dangers or side effects that they will have if they stop taking their medication, and the kind of importance of doing that under supervision. So that kind of drops down to a score of just under half. The one that we've kind of flagged in red there is that single question where you fall in the bottom 20% of trusts across the country. And that's again about having an annual review of how they are getting on with their medication. So 73% of people said that they did have that. But again, that's quite low compared to other places in the country. Quite positively, and one of the ones that we see really high across the board, across the country, is about having privacy to talk comfortably when receiving talking therapies. So a score of 87%, just ahead of the sector, but still in that kind of middle 60% of scores. Then moving on to crisis care. So again, really positive, first of all, that service users will know who to contact out of hours if they are in crisis. So up at 83%, that is ahead of the average in the sector. And for all of these scores, you are kind of ahead of that sector benchmark. So getting the help that they needed and the time that they took to get through to that team, positive scores for yourselves. And then at the bottom, in particular, we wanted to call out that you're in the top 20% of trusts for giving the family or carer support whilst the person is in crisis. And there's a similar question later on about providing support to family and carers, which I know has been an area that the Trust has been working on, as it used to be a relative weakness. So it's really good to see the scores that are improving in that area. And then the final section is around the additional support and wellbeing that you provide to service users. And just in general, we see that these scores are lower for the sector. So particularly questions 32, B, C and D, much lower scores than we see in the rest of the questionnaire, around the kind of 20 to 30% mark for all trusts. And part of the reason for that, I think, is because the NHS team is often signposting to external providers or other parts of the ICS to supply that support. But in particular, question 32B, you do lag behind the sector a little bit in that question, 19.4 compared to 21. So it's really about kind of reviewing what materials are available to service users and how you're signposting that external support. We'll just touch on the one green spot there. So again, a question where you're in the top 20% is about helping people to join a group or find an activity, participate in their local community, despite their mental health problems, or in order to help with their mental health problems. So that's a really positive score at 47% and near the top of the sector. Down the bottom, there's a couple of questions added about the additional support to access your care and treatment. So that's things like physical kind of access requirements to help with people's physical needs, or in terms of kind of languages, different formats of materials. So it's quite a broad question, but really key that that last question, do you feel that support provides and meets your needs? 55%, so 5 percentage points ahead of the average in the sector, shows you're really positively including everyone and providing as much support as possible. So just to summarise, obviously the majority of the trust scores are in that middle 60% of trust in the sector, but there's 5 in the top 20%. And really the kind of highlights for me are kind of where your relative strengths are, offering support to service users between getting their first assessment and then starting their treatment. Considering the whole person and how all areas of their life are impacted by their mental health. And providing that support to their family and carer, particularly whilst they're in crisis, but at all times. Areas to focus on. So there was only one question where you were in the bottom 20%, and that was around the annual reviews of medication, making sure people are aware of kind of how they're getting on with their medication, what side effects to report, and what may happen if they stop taking it. We looked at the kind of new introduction of the question about care plans, and making sure you understand if there's any specific services or areas or demographics of people that don't think they've had a care plan, and making sure you've got that written documentation in place. And then finally, in that last question, generally low across the board, reviewing the materials that are available to service users to support them, particularly in keeping work, but the other kind of external sources as well. And then just finally to summarise the next steps kind of we recommend for you to take with the results of this survey. So the organisation will have received lots of breakdowns of those scores in different services and different groups of service users. So it's really kind of pulling that data more apart, get into detail. Are there any individual services that need particular attention? You've also got the free text comments that came through from the survey, which is really important in kind of telling those user stories. You might need to dig deeper to kind of understand those issues further, but then it's really about making sure you put an action plan in place to address the key issues, and engaging service managers as much as possible to drive those action plans forward. And then obviously implementing those action plans, really important so that we can see the improvement in years to come. So that's all the slides. I'm happy to take any questions.
Thanks very much, Elaine. That's really helpful. And actually the slides were really clear. Thank you for that summation of what the findings were. It is disappointing not more people, actually service users, took part. And I noted that from the start of what you said, and that how we contact people as well. So that's really important. Can I just ask just on that before I open up to everyone else, given this was the first time that you said that 16 and 17-year-olds had been involved, how many of those actually were engaged with and responded? Are you able to tell me?
Yeah, just a minute.
Thank you.
So I don't have the actual numbers, but 5% of the people who responded were aged 16 to 17.
Thank you so much. That's just helpful for the context of this new engagement of the survey. Okay, right. Thank you for that. I'll open it up. Mike, I've got Mike, and then I've got Stuart, and I've got David in that order. Mike.
Thank you, Chair. Thank you, Elaine. Very clear presentation. One of the things that it highlights, though, is that when we're in the top 20%, for example, for involvement in care, the sector as a whole has a pretty low score. So I think perhaps for Mandy, what's our feel in terms of the real world? Never mind what we benchmark against, but in the real world, does this show a good performance, a mid-ranking performance, or any areas of concern?
I'm going to ask Natalie, who's joined us from the division, to take that question, Mike. Natalie, as Natalie is involved, directly with patients and carers and service users in our trust.
Okay, thank you, Natalie.
Yeah, I think first of all, it's really important to see the data that we collect from this survey, not on its own. It very much has to be taken into consideration with friends and family feedback, from peer reviews, because just like all sets of data, this one very much has its limitations. I think if you look between the trusts, and it's the same with the amount of people that are feeding back in, the differences, even that what would get you into medium, low and high, are very, very marginal. So I think my answer would be that I think we are doing well out there, but I would really, I guess, warn against taking this data on its own to make those decisions.
Mike, did you want to come back on that?
Yeah, just turning my mic on. Yeah, that's very clear. But and I think that your warning is well received. It's too easy sometimes to look at the figures and say, well, everything's all right, but because it's 98%. But what about the 2%? Are they actually really, really worrying? So thank you for that, Natalie. I'm grateful.
But at the same time, I would just say that we do take this survey seriously.
Oh, yes.
We do, because it is an important component at which it happens across, obviously, the NHS, and clearly, we have to match that against other areas. But there's lessons from this and indications that I'm sure we're all aware of need to be looked at further. I've got Stuart and then David and then Phil.
Yeah, thanks very much, and morning, everyone. I'm sort of fishing in the same territory with my first question, and I think you've answered it partly, Natalie, that there's more digging to be done, particularly, I guess, in the free text. But my question is, we've got the raw score or some single scores from Elaine's really helpful presentation. Are there any indications that we've got some really deeply unhappy people around? And if so, what are we doing about it?
I think, again, with regards, we can look into the subtext into that, but I think, and notwithstanding Caroline's point that we do take this seriously. People know, unfortunately, I've been absent from work for 2 months, so this work has moved forward without me, so I'm not as informed as I would usually be. But as you guys know, I was very keen to take this back on this year after working with it last year. So I'd just like to reassure you, Caroline, that I do take it very seriously. But I do think, again, the answers have to come from that. Specific answers have to be taken from more dynamic results from around teams, that then we can build dynamic answers into those teams, because it's very hard. I think this must go out to about 20 teams, so it'd be really hard to get the answers. A few people from here, therefore this team are not doing well enough in this. And I think we do have to be able to give dynamic answers. This provides us with some system-wide opportunities, but I think when you get down to the nitty-gritty, there are better ways of addressing those issues.
And what do you mean by a dynamic answer, Natalie? Just unpack that for me, would you?
Well, for example, the Friends and Family tests provide us with data specifically for teams. So if you were going to ask the question, do we have a set of pet patients that is particularly unhappy? Let's say that I have a team in my area, one of my CMHTs or PCMHNs, that are frequently coming up with poor scores and poor feedback from friends and family tests. I would know dynamically at that time in that team that there needs to be some significant work that's very tailored to them. What we have the opportunity to look at with the service user survey is almost the bigger picture stuff. Okay, so when we may not be able to focus directly specifically on specific teams, but what can we do to improve these scores on a broad basis? For example, we do score poorly in the medication understanding section year after year, to be honest, but again, it's very minute details, and we've had Leah working with us on that. But what that gives us an opportunity to do is look again at the information that is sent out trust-wide, at the ease of connecting with that. We can scope out which teams know about it and which teams don't, which teams know where to get to it. But it's not going to give us truly dynamic answers that in this team, this is a serious problem. So it needs to be seen in a broad spectrum, and we can't take it out of context in that way.
Understood.
Nor should we. Just like all the data we get, it's important, but it has its limitations.
Yeah, thanks, Natalie.
Thanks, Natalie. David.
Thank you, Caroline, and thank you for the presentation. I've got two questions, if I may.
David,
yes.
Have you got some? Is there some noise behind you or something?
Oh, I'm having problems with the microphone. Is it?
It sounds like there's either a wind rush going on behind you. Sorry, I don't know.
Can you hear me?
We can hear you, but there's a little background noise there, but it's not too bad. We can hear you. Okay.
So two questions, if I may. First, going right back to the beginning of the presentation, Elaine, you talked about the low uptake due to the lack of telephone numbers, so we couldn't send the SMS reminders out. Now, surely telephone numbers are a basic contact information that we get for all of our patients. So does that correlate with what we hold on our systems? If we're not getting mobile numbers for patients, then there's a bigger issue there. Does some of the other stuff correlate with what our own systems tell us around, do people have care plans, are they having care reviews? If our systems are saying that 90% are, and the survey's saying that they're not, that it's a communications issue. So there's a data question there. And then my second main question is around the support and wellbeing responses, which were very low. There was an implication, I think, that people weren't happy with the support and well-being that they were getting from where we were referring them to. Do we know that's a fact? And if that is a fact, what are we doing about kind of increasing the capability of the people that our partners that we are working with?
Shall I take the second part of the question, Elaine? We know that's a fact, David, for a few of the patients that answered as such in this survey. We know that's a fact for a few of the patients that answered as such in this survey.
So we know that we are referring onto agencies that aren't giving them the support and well-being, the well-being support that they need.
We know that's a fact for the few of the patients that answered as such in this survey, yeah.
I'm a bit confused. Sorry, let me just understand a bit better. Is that a particular issue for those patients, or is that around those providers that we've referred to that aren't delivering?
Okay. Again, that would be to look at the free text to get a better understanding of that as to what these particular patients were concerned with.
Well, I think it's more than because the scores were quite low, weren't they? So there was only 50% that were satisfied. So I'm assuming that over half, almost half, aren't satisfied. So is that work going to be done to pull that out? Kind of what the issue was?
Yeah, definitely. And we've got that on our action tracker. I think that was the one for me that was by far and away the most surprising, because in community mental health, as in the CMHTs and PCMHNs, more money than ever has been pumped into that. We've got more broad services. So we really need to understand what that's about. And I don't think we do yet, in all honesty with you, David. But that the wellbeing question was my biggest surprise.
Okay, thank you. Where will that get reported back to the board?
Yeah, we've started our, as I say, I've been off for 2 months, and I very much lead and propel this work forward. And I will say, not to take all the credit for anything, but it has stumbled in my absence. So
okay.
We'll be in a better position.
Okay, all right. When we finish this conversation, I'm sure with Michelle, just to say, Michelle, it'd be good to wrap up what we do with this information going forward, because there will be an action plan come out of this, absolutely certain. And I'm sure whether it's the quality committee, or for that matter, we might want to look at it at the strategic board a little bit more as well, in terms of what's behind some of the figures. That's something I'm sure, I'm looking to Michelle on the screen, that we can take forward, and I'll ask Michelle to come in at the end if I may. But you're absolutely right, David, correlating what information we've got on mobile numbers generally across the piece against these people's experience is really important to look at. Likewise, the care plan side of it as well. And that's the issue around samples, isn't it? If the sample's not bigger, how does it fit against our understanding of what's going on? Is that all right, David? Elaine, can you can I just sort of, I'll come back to you a bit later, but we've got to get through some questions here to take away, if that's all right. Thank you very much. Elaine, was there, Natalie, that was. Elaine, was there anything you wanted to add to David's points?
No, I don't think so. So that would have been flagged by our data team kind of when you sent the data to us. So I'm not sure whose responsibility that is within the trust to go back and review what data is held.
Okay, thanks very much. Thanks, David. Phil.
Yeah, just to say that I'm happy to bring through the issue about patients' view of their medication reviews through to quality committee, but I need to discuss it with my executive directors to see what's work's already been done and where we are and whether we need to make a big deal of it or not. But I'm happy that we'll pick that up.
Thanks, Phil. Thank you. Kwame.
Yeah, no, I'm happy for the action plans which we did. There were 2 questions. One was about Initial, which we did make a lot of progress on that, and we did quite a lot of things around giving patient leaflets, giving patients, sending them to areas where they can, after the consultation, be able to look at side effects and things like that. So we have to review it. I think one of the things which I was going to bring to the conversation is whether we need to broaden it, instead of the focus is only on doctors and pharmacists, because there are quite a lot of professionals who are also prescribing medication in 2024, to broaden it. Hopefully, I think we were 0.8% of the getting to a good target. So we'll work hard on that. In terms of the well-being conversation, which David was talking about, I think last year, again, the whole sector was quite low, and we did go back to IQVIA to see whether we could speak to the areas where they've done well. I think I spoke to Elaine about it before the presentation, and she was saying that some of the areas where maximum figures were 30%. So it sounds like all the sectors are struggling to convey that message. And I think that those are some of the questions that because we were hoping to find an organization that was achieving 50% or 60% to say, what are you doing different, so that we can copy from last year, and we couldn't find any organizations. So we might have to go on the drawing board ourselves and see if we can find different novel ways of making sure that patient directions into well-being services and care improves our performance and help the patients.
Yeah, I suppose part of it is just how we put all the information together to see that there's consistency across the piece that's been applied. So board may remember that we had a really interesting presentation at the last Council of Governors meetings, one before last, in which it talked about our support services for helping people to get back into work. And we heard from both the service user and a staff member. And I think both governors and board members came away from that really interested. I mean, it was really interested and it was real. And I suppose it's just about how much of that is being applied across as an offer to our service users as a matter of course. And that's probably something where the data connecting together can give us a better idea of how much that is happening for every service user where it's appropriate. Michelle.
Yeah, thanks. I'm conscious of time, so I'll hopefully conclude the discussion. I think it's been a useful conversation. So, first of all, thank you, Elaine, for a really good presentation, and thanks, Natalie and Mandy. Just to say, there's been a couple of things that I suppose with this. I said that I always point out, I'm always disappointed at the low response rate. I think we've mentioned that because it's a low response rate and we have to increase that uptake, and we've had a lot of conversations about that. Can I just say this is taken exceptionally serious? This is one of the main reports that we have about service user care that we get into the organisation. So the executive management team has spent a lot of time working through this, and we have I know ODG have in relationship to the division, and I know the division are doing some detailed action plans which will go through our governance processes and the scrutiny of that. It is exceptionally disappointing in relationship to the medication. And we've had a lot of conversations about that because it's the one, and we've looked back to 2018. I know the survey words have completely changed a little bit, but it is the one that we've been struggling with, to be honest. I think that's the right word. It's for one that, for a long time, and we need to get that right. But we also need to get that response rate right, because even though the survey overall is a relatively positive survey, when you look at it, the response rate, when you compare that with the response rate, we don't know, I think is the answer. So we need to increase that response rate to look at it. So we've had some conversation about the executive management team. Can I just say, there has been a couple of comments today. We haven't just been stonewalling this or not doing anything in relationship to this. We've done a lot of work through the divisions, through the quality groups, especially with Sarah Bradshaw and Kaylee, who have been leading a lot of this work and doing the detailed action plans. We didn't feel it was right to be in the detailed action plans per board, but they will go to quality committee. So I would appreciate Philip's and other people's viewpoint on those when they come. For that assurance that we're ticking the right areas, we're looking at the right areas, that we're and the actions are going to help in relationship to the outcome. We are trying to see some of the other organisations that are in that better spell than us, because obviously what we want to do is that constant improvement, and we'll constantly do that. But I'd like to use a conduit of the quality committee to bring back further information to the board, and I do think it needs to come back to the board relatively quickly, because we have done those action plans. I don't know the timing of the quality board offhand, but I'm sure Philip will do that. So I'm sure it'll be on the next agenda. So maybe if you can do some deep dive into that action plan, I would suggest, and then bring that back here. I think that would be really helpful. But just tell us some things, and there are some really positive things in there. There are things that we need to improve on. I do agree with Elaine that sometimes it's the wording of the care plan, that people have got a care plan but don't really fully understand it is a care plan. So it's about how do we acknowledge that. And don't forget, we do get that metric every month at the board performance report about if you've had your care plan reviewed, both of it in 12 months, and also from that follow-up as well. And as you know, it's one of the things I'm really follow is that 12-month review. So lots of good things happening. Thank you for the presentation, really helpful. But we are taking it forward, and we are taking it really serious. And we've got lots of people working through that. And I know we've got lots of exec directors that are particularly Hilary and Lynn, that are looking through it as well. Hope that's helpful just to conclude that conversation, Caroline.
Thanks very much. Natalie,
very quickly, Caroline, I just want to reiterate that Michelle has just said we are taking it seriously. I led this work last year. I'm leading this work again this year. I volunteered to do that. We are taking it seriously. If you actually look at some of the results from last year and this year, we've made some really, really good progress. And for example, things with crisis, amazing difference. But just to really reiterate that we are taking it seriously.
Yeah. I know we are, because I know there's other pieces of work. I mean, we've had discussions, I think, in this forum and other forums around medication. Even recently, I think we've had some discussions around that, and in other areas as well. And as I said, I know for some service users, we've done some excellent work, because I've heard it from a service user in terms of getting into employment. So, I mean, you know, that's a real feedback. I think it's basically from the discussion is how do we make sure that we can match what we've heard from this report, which is really important, against what we're doing, where there are areas where actually there's improvement. And I think from this discussion, just to summarise, from what Michelle said, first of all, the medication does need to be looked at. Despite everything we know we've discussed around medication, it does need to be looked at, because clearly we need to assure ourselves that patients are aware of side effects, are aware of what happens if they stop taking medication, and that should be a habit-forming thing for those discussions. Secondly, as Michelle said, that we'd like Phil Quality Committee to have a deep look at those divisional action plans and report back to board, and we can sort out the timing of that and how that might work. But we've got a board in September and there's another one in November. Let's work out which one of those two are feasible. It might not be for September, but definitely if November board is, I think, doable. Hillary's nodding there. Thank you very much for that, Hillary. And then thirdly, I think it's about the uptake, as Michelle said as well. If we have got, and again, we need to match that against the experience of other service users as well in that space too. But I think this has been, a very good discussion, open as well, and very welcome. So Elaine, thank you for that. And Natalie, welcome back to the Humber after your absence, and really appreciate the slides. I don't think we got the slides before. It'd be good to share the slides with board, I think, as well, post meeting, because they were really helpful as a sort of, to remember and also to think about it against other information that we get in this space. So thanks very much, Elaine. Thank you very much, everybody. Thanks, Natalie. Thanks, Mandy. Okay, right. We will move on now to item 6, which is the National Staff Survey results. And we have Charlie with us, and I think Vicky's with us as well. Is that right? I've got Charlie.
Not today, Caroline.
Not Vicky. Got Karen. Yeah. It's all right. We've got Karen. So we've got Karen. Can I hand over to you and Charlie, please?
You absolutely can. So good morning, everyone. I'd just like to introduce Charlie, so a colleague of Elaine's. So Charlie works for and comes from IQVIA, who administers our staff survey. So I know that we've heard a lot about our staff survey over the course of the last few months, but Charlie is here to formalise it from IQVIA's perspective. So Charlie, without further ado, I'll hand over to you.
Thank you very much. Hi, everyone. I'll just share some slides. Hopefully it's not death by IQVIA slides for you all this morning, because these will look very similar to the last set you've had, but I'll try to make them interesting and engaging. The good news is they're good results. So it's always nice to present good results. Okay. I don't have as long as I normally do to deliver these, so I will skip through some slides quite quickly, so we can pick up things. If I skip past something you're really interested in, we can pick it up at the end in questions. Sorry, I should say, I'm Charlie. I'm from an organisation called IQVIA. You know IQVIA well because we've just presented to you. We do lots of these presentations, not just for the staff survey, but for others, such as Mental Health Community that you've just heard. We remind people within our presentations why staff engagement is so important. And I know you as a trust, because I've met and spoken to many of you, I know you take this stuff really seriously, and it shows in your results, and I imagine shows in terms of better patient care or service user care. There is this growing body of evidence that connect positive staff engagement with better patient outcomes. So it's not just the obvious link between staff engagement and patient experience. So happy staff equal happy patients. There's actually evidence that shows it can improve outcomes as well. So it's more important than ever that we focus on this stuff. There are 2 surveys. So there's a main survey and a bank survey this year. Just to remind you that these are the views of your staff from last year. So when I say this year's survey, I do mean 2023. and when I say last year's survey, it's 2022. And as we go through the presentation, there's a comparator which shows how you're performing. That is compared to other organisations that are contracted to IQVIA, apart from one slide at the front where I've got I've put the national results in. First thing to look at is response rate, which is a really good early indication of how engaged your staff are. Now, the response rate here is excellent. You had a really significant improvement between 22 and 23. You can see 55%. Way above average, which is always under 50%. It was 48 it was this year. And that's a fantastic indication of a really engaged workforce, and I'd imagine a team who are behind the staff survey who have worked really hard to get people to respond to it. It's really, really effective. It's a great response rate, and you should be really pleased with that. Also, bank staff is a fantastic response rate. Bank are a really challenging group of staff to engage in the staff survey. The fact you've had almost double the national average response rate is fantastic. I imagine, again, indicates you've probably got quite an effective staff member in charge of bank staff. So really, really good response rate. We're often asked what can trusts do to improve response rate. Really, by far and large, it's the response from senior management at the bottom of that list there that drive response in the future. And the response from groups of staff such as that I'm presenting to you today, so board level individuals. And you said we did continues to be that really effective model to demonstrate to staff that you've made changes as a result of their feedback. So this is a slide I put just up front to reassure you all. These are really, really good results. They give an indication of a really well-managed organisation. It's continuing to improve the experiences of staff. There are some areas you will want to focus on to improve, of course. But what remains, we're still recovering post-COVID, and it remains a really challenging time. Lots of other pressures in the NHS. The results show a really well-managed organisation that's responding well. So do bear that in mind. From an independent perspective, these are really good results. So first thing to look at are the people promise themes. These are kind of the top level themes that sit above all the questions. And your organisation is the dark blue bar in each of these cases. And the light blue bar is the average result. So you'll see in every instance, the results here are better than the national average. There is no comparison for safe and healthy at a national level, probably due to the level of responses. However, if you look at our data, which looks very similar to the data you've just seen from Elaine, so you'll know what these slides mean. You'll see that you're better on everyone as well, but we are always learning. You're actually significantly better than the average. So we've got 3 columns with scores on all these slides as I go through: last year's, this year's, and then the sector comparison. And in between each one is a significance calculation. So let's go on and just look at some question level scores. So these are the ones that sit underneath the people promises. In terms of benchmarking you to how you're performing sector-wise, you've got a vast proportion that are in that top performing category. So 28% or so, getting on for a third of questions are in the best performing category. You are better than the sector in a way that we would say is statistically significant. Just one that is lower, and I will point now as I go through, and then a big proportion that are actually in the middle, showing no significance. It's really important to point out that that's actually a much better position to be in than you might have thought 5 years ago, where you want to see more in the top range. Actually, trusts that are around level are doing pretty well at the moment due to the nature of staff engagement in the NHS. So this is a really good indication of positive staff. This slide might look a bit similar, shows you the changes in questions between the last survey and this survey. I think this is the most positive reflection on what must be happening within your workforce, in that no questions have got worse in a way we would say is significant. So every question level score has either stayed about the same or got much, much better. And it's about the same proportion. So getting on for a third that have really, really improved since 22. So that's really, really positive. There are now a number of slides that look like this, and I'm going to skip through some of them because just of time constraints, and just point out the really interesting scores. So this is staff engagement. It's measured across 3 themes: motivation, involvement, and advocacy. And I'm going to go straight to advocacy because this is the most important one to keep your eye on. And this is where the CQC look, because it's where the NHS staff, friends and family test questions are, which they think are really good benchmark of how engaged staff are, and they're right. So 25 C and D, which is staff recommending the trust as a place to work, and secondly, satisfaction with care if a friend or relative needed treatment. You'll see both those scores have improved in a way that we would say is significant. That is fantastic. They're both above average. The second one, which is satisfaction if a friend or relative needed treatment, is significantly better than average. They are really encouraging improvements. I'm sure you'll be really pleased about that because they are really important scores that external bodies do look at. You just want to keep your eye on that top one. Hopefully next time round, it will be significantly above average, but really, really good scores, really good improvements. Morale is also measured across 3 themes: staff thinking about leaving, work pressure, and then the HSE stress index questions. These first ones, you'll see a shaded pink. That means they're negatively scored. So you want a lower rather than a higher score. And so in all instances, the score is going down, which is what you want. Really, really encouraging. In particular, we always say to have a look at 26C, which is your group of the most disengaged staff. So that's staff you say, as soon as they can find another job, they're going to leave. And your score's really good here, 11%. I mean, you will think that's probably quite high. It is high across the NHS. That's really important to bear in mind. You are below average, which is what you want. And you'll see it's a sea of green. So it's definitely telling you, well, the data is clearly telling you morale is improving in a way we would say is significant. And in many instances, morale is much, much better than in comparable trusts, in comparable organisations. So good scores. And in terms of stress, nothing really significant in terms of negative impact, and some improvements around time pressures. And again, you're above average in terms of having a choice in how staff do their work. Stress is a really good one to look at by department. Often there are real differences in location. So it's a really important one to look at, particularly those that have direct contact with service users generally experience higher levels of stress or report higher levels of stress than those closer to the corporate centre. But it's important just to have a look at those breakdowns. However, scores are good here. People promises, this is the compassionate and inclusive one. You'll see lots of improvements. Some of the questions are used more than once. So you'll have seen these ones already. Sorry, I'm going backwards. This is a really interesting section, compassionate leadership. There's lots of evidence that ties the scores within compassionate leadership to other sections of the survey. So these can really drive other areas and really improve staff engagement. The scores here are all really good. What you want to do as an organisation that's striving for excellence is to focus on this area and try and improve these even further. Because this is line managers going the extra mile, if you like, so really caring about the experiences of staff, helping them with problems that they might have outside of work, helping them reprioritise their work if they're struggling, that sort of thing. And it's really good. Scores are good, but in particular, you've got a big improvement around line managers actively listening to staff. Which is a really challenging one to get right. Good scores around diversity and equality. The middle 2 are the ones to have a look at, and in particular 16B, which is the second from bottom. So when it comes to discrimination, HBA and violence, CQC look at all those 3, and in particular they're looking at, is there an issue within the organisation? So not necessarily discrimination from the public, but is there an issue between members of staff? And the answer is no here. So 16B, which is experiencing discrimination from a manager or colleagues, the score remains low. It's really good. Again, I'm sure as an organisation you'll say, well, we don't want it to be 5% even, but do bear in mind in the context of the NHS, that is a really positive score. However, you'll want to have a look at where that's happening. It will almost certainly be location specific, and you can probably do some targeted work to improve that score. Good scores around inclusion. This doesn't surprise me. In particular, what comes through in quite a lot of the other scores is the way in which staff treat each other, and the fact they treat each other with kindness and respect is really important and will definitely drive staff engagement overall. So the fact that comes through quite clearly, that staff and colleagues work well together and treat each other kindly, is a really good the staff engagement and the morale within the organisation. This slide just shows you of staff who are experiencing discrimination, what does it relate to? And this looks the same in most organisations in terms of ethnicity is generally at the top. But what the data tells you here is that actually staff are experiencing discrimination based on their ethnicity, but actually at much lower levels here than in comparable organisations. But interestingly, staff are experiencing age-based discrimination more within this organisation than in comparable trusts. Bear that in mind in the context of actual rates of discrimination are low. So this slide is these questions are only shown to those who took yes, which is only 5% of staff. But it's definitely telling you something. So it could be an age-based discrimination issue in a particular location. Might be worth having a look at. But again, bear in mind actual rates of discrimination are low. These two questions are new. So this is about unwanted sexual behaviour, firstly from patients, secondly from staff. Both scores are okay. We think what's happened is that staff generally, due to the work OD and HR have done, are more likely to call this behaviour out. So it's not necessarily identifying new behaviour. The one to keep your eye on is where it's happening internally, of course. Your score's lower than the average, which is really important. But again, your 2% is more than it should be. And so do have a look at that score and you might be able to identify any patterns of where that's happening. Really good scores around adjustments. This is staff who might be living with a long-term condition or need additional support to carry out their work. And really excellent score actually for staff who feel they need extra help. They're very likely to get it here. And much, much higher than in comparable organisations. So I imagine that ties into work you have done around working with staff that need that additional support. Staff being recognised and rewarded, the most important one to look at is satisfaction with pay. That has risen across the board due to the NHS pay increase, we assume. However, what the data really clearly shows you here is that it has risen to a much higher proportion than in comparable organisations. So you're 10% above the average. Now, satisfaction with pay in the NHS is low, but it is low in every organisation we work in. It's no different here. The average is about 30% in any organisation. Even when we work in the corporate sector, generally everyone wants to be paid more, which is not surprising, I suppose. But actually the score's risen here quite significantly, which definitely indicates not only are staff pleased that they got a pay rise, but actually they're really well engaged with the organisation and morale is improving and the people are more satisfied with their managers. So really, really good. That's really, really positive finding, that one. Staff having a voice that counts, generally speaking, scores are okay here. I'm not going to point them all out because there's nothing particularly interesting. You'll see it's all not significant changes. However, raising concerns, two really positive scores. So staff feeling safe to speak up and feeling confident that the organisation will address their concerns. Those two scores will drive the other ones. Where staff feel that the organisation will take action, they're far more likely to report a concern in the first place. And this is errors and near misses. Very similar story, but really good improvements at the bottom in terms of, again, the organisation taking action and giving staff clear feedback around what's taken place. And at the top there, in real terms, staff actually witnessing errors and near misses is low compared to other organisations. That is an encouraging finding. Staff being safe and healthy, these are, again, really positive scores. In particular, 11A is the one to keep your eye on, which is organisational action on health and wellbeing. Not only has it improved significantly, I mean, really noticeably, scores in the staff survey don't generally move that much. So where it moves 7% or so, definitely telling you a really positive story. I'd imagine that means you have done some significant work within health and wellbeing as an organisation, and you're well above average. That is really encouraging. In order to improve that score even further, we recommend using all different channels to communicate health and wellbeing initiatives for support staff. Not everyone's in front of email all day, but actually the scores are really good. So generally speaking, health and safety, excellent within the organisation. Scores around burnout, all pretty good. Nothing flagging a particular issue here. These scores are high across the NHS, so staff are experiencing burnout at quite high levels if you look, but actually this tells you there's no issue here when looking at comparable organisations. And negative experiences, these are all negatively scored, so you want these to be lower scores, just to remind you of that. The ones to point out that the CQC will look at is 13B and C in the middle there, and 14B and C at the bottom, which is firstly violence from managers and colleagues, and then secondly bullying or harassment from managers and colleagues, so where it's happening internally. None of this is showing an issue. So violence from managers is low, 0.3% you'll see, and violence from colleagues is also low, 0.6%. I'm sure as an organisation you will want that to be 0%. There is no organisation that gets 0. That's important to point out. And perception plays a huge part in violent incidents. A slamming door is a good example of something we get reported as violence, which isn't. The scores are all good, not showing any issue. Staff working additional hours, no particular issue. In fact, unpaid hours has improved. It is high. You can look at this question positively. It means you've got a really engaged group of staff committed to delivering excellent patient care and as a result are working extra hours. However, it will lead to burnout. So do keep your eye on that one. This is a brand new score around access to a nutritious and affordable food. Your score's good, slightly above average. Lots of trusts don't know where their scores are coming from. Some don't even have canteens and are getting excellent scores. So it's a mystery. Could be because people are bringing their own food in, perhaps. Learning and development, really positive. Again, lots of improvements, in particular, when they need to develop their career, they feel there are opportunities to do so. Not sure how I'm doing for time. I might be going over. Appraisals, some noticeable improvements. The one to focus on as an organisation is the bottom one because it's good, but you'll want it to be significantly better like your other score. Because where staff leave their appraisal feeling valued, and it's an ideal touch point between a manager and a member of staff, their morale and their engagement will improve even more. So that's one to have a look at within appraisals, but the scores again are positive. And access to appraisals is excellent. I think you are our best performing organisation of all trusts we work with. 94% coverage of appraisals is excellent, and it will probably be higher than that. It's just not everyone recognises they've had an appraisal, so might not tick the box. But that is a really, really good score. So access to appraisals is excellent. Flexible working, again, really, really good. Really challenging one to get right at the moment. But actually, looking at these scores, you can see that staff are able to balance work and home life, are able to access flexible working opportunities, which is really important. This one, I just want to point out one score, which is right at the bottom. I think it's really interesting. All the other questions relate to how teams work within themselves. And generally speaking, staff report positively on that. The bottom one is how teams work across the organisation. So cross-organisational working is a really challenging area to get right. Most trusts say we work in silos, we don't communicate. That's not the case here, and it's really improved. So I hope that's down to some work that you might have done to facilitate cross-organisational working, because that's a positive improvement. And then good scores around line management. This doesn't surprise me because this will drive other improvements in the survey, particularly around line managers taking an interest in health and wellbeing. So here's some recommendations for substantive staff. I've then just got one slide to look at bank. These are excellent scores, so do take that on board. Take time to recognise this and celebrate it with staff. It's a really challenging time in the NHS, and it's easy to get caught up in action planning, but do take a step back and think you've done really, really well. Almost everything is improving, particularly the FFT questions. So continue to look at those because you want those to continue to improve further. Age-based discrimination, if you remember, definitely have a look at that. Rates of discrimination are low. It's not an issue, but it's telling you something. So have a look at the data to see. And HBA, where it happens, do encourage staff to report it. I think that score might have been slightly lower. So I'll just skip through bank really, really quickly because I know time's a bit limited. So looking at bank compared to substantive, actually you've got a huge proportion of scores that are better. This is very slightly different than in other organisations we work in. Generally, more scores are lower comparing bank to full-time staff. So that indicates a really well-engaged group of bank staff. Just 2 have improved, but most importantly, no questions have got worse since the last survey. And if you look at staff engagement, you'll see, generally speaking, really good in scores around motivation. Involvement is lower, but it is lower in every organisation. Bank staff less likely to be involved with the organisation, of course. And the advocacy scores are still good. The FFT scores good for bank staff. And good scores around morale, other than the one around being involved in changes, which is not surprising. So this staff just summarises it really. Bank staff come through really positively in this survey. Again, that must be due to an effective member of staff. They report less positive to questions about immediate managers feeling valued. That is the case in every organisation. But that can have a bit of an impact on health and wellbeing. So where possible, do try and involve bank staff. So these are the recommendations. I got ahead of myself. So you might want to have a look at health and wellbeing with bank because it does really well with your full-time staff, you might want to try and improve access to those initiatives amongst bank staff. Try and listen to concerns if bank staff raise them. I don't know how the bank line manager relationship works. And do have a think about access to appraisals, because your appraisal system is clearly excellent and really well received. And this slide looks really one you saw with Elaine, so I won't go through it. It's really the 4 steps you need to follow to improve in any other areas. Most importantly, to point out, we are here to support you in any of this. So if you need external support as you start to action plan, just get in contact with any of us. Happy to take questions. I'm really sorry if I've gone over, but I just wanted to point out your excellent scores.
No, thank you, Charlie. And sorry we couldn't have you at the last board meeting, but a general election got in the way and we weren't able to have you
there.
Yes,
all right, no worries.
I mean, you'll be aware, and just to sort of, make this clear, for anybody looking in, we actually obviously started looking at these outcomes about 2-3 months ago, I think, actually, in our strategic board. And I know Karen's been doing a lot of work, but as always, it's really helpful to have an independent set of eyes helping to remind us on it. So it's really great to have that, and thank you so much for that. Questions from colleagues on the board. Let me just have a look. I've got Mike and then I've got Dean.
Okay, first of all, thank you, Charlie. That was an excellent commentary and really brought the statistics to life. So I'm grateful for that. All of these things really involve leadership and strong leadership, and a term that I've just invented called one Humber. And it seems that the cross-working, starting from the EMT, seems to be really successful. But one thing I have thought about is when you see really big changes, you think, well, what was different then to last year? And there's been a major change in our HR department, and leadership from there could be a factor. And I'm starting to wonder, is it possible to interrogate this survey and look what change there has been in the HR department from what feedback you've got from members in that department? Or am I going down a blind alley?
Thanks, Mike.
You can absolutely do that with the data, and we would encourage it. It's a really interesting point to make. I think that probably will have driven some of the improvements. Yeah, we give you access to our reporting tool called Solaris, and you can log in and cut the data in any way you like. So do have a look by department. I think that'll be quite interesting.
Thank you.
Thanks,
I like
Mike.
the one Humber bit as well. Good stuff.
Yes.
Thanks, Dean.
Yeah, thanks, Charlie. And as Caroline said, good to see this now. As we start planning for next year's staff survey, and I know Karen and the team will be well underway with that. So it's a nice, timely reminder. I know we've discussed this at sort of workforce committees, and I brought assurance reports as well, but good to see the formal sort of presentation here. I just wanted to add if you like, the longer term picture as well. So 5 years ago, 6 years ago, that position was reversed. I think we were the lowest 20% in many indicators and nothing in the highest one. So I just wanted to pick up that, we talk about culture change taking time, and I think this is evident of that. But it's also great to see that persistence in terms of working at it, as Mike said, through leadership over that period of time, and to see that sort of paying fruits, because it is about intentionally doing that week in, week out that makes those differences. And no doubt we'll be looking a bit like the last survey, which are the organisations that are scoring in the highest 20% in other areas, so we can continue that continuous improvement, really. But thanks for the presentation.
Thanks, Dean. Karen.
Yeah, I think I just wanted to reinforce that these results are a testament to hard work across the organisation, and I don't think any single department can take the credit for that. And I know that's not being suggested, but I just wanted to reinforce that, particularly if you look at areas such as reporting incidents and near misses, etc. A lot of that work is a testament to what's happening in nursing and quality. Equally, if we look at some of the divisional responses, that's under Lynn's remit, and I think it's a big pat on the back for everybody. Really, it's a collective responsibility. I think EMT last year particularly, as we have done over the course of the last few years, but really honed in on some key areas that we wanted to see some improvements, particularly around the question around care of our patients being the organisation's top priority. And that senior influence and attention really did get behind that, and we've seen that come out in the results. So I just wanted to reinforce that, because I think there are so many people in this room and in the organisation that should be incredibly proud of the progress that's been made over the course of the last few years. And it just makes me slightly nervous going into, I think I'm adopting Michelle's mindset of last year, being slightly nervous going into the next survey, because these are excellent results and the pressure feels on for me. But yeah, it's great. And I think many people should be applauded for that.
Thank you, Karen. I'm sure that is echoed by everybody else. What I think is really reassuring for me, looking over the last 3 years, is how certain elements we've identified when we've had previous years' discussions. For example, recommending as a place to work, recommending to your family to use our services, and they have really improved, but not at the detriment of other indicators. And I think that's really important as well in all of this, because there could be a danger that you just focus in on one area and, some of those go the other way. And likewise, I know, and we've had reports to board and about innovation around getting take up as well. And again, that's been really reassuring. But at the same time, I was just, things like around, sexual abuse. I think, again, things like, getting behind the Sexual Safety Charter, doing more work on that front. It's not necessarily a bad thing, is it, that we are getting more feedback on that through this and in other ways. It's sort of reassuring that some of that work is playing out in terms of people being confident to raise these issues. But the age discrimination one is an interesting one. We have discussed that, actually, haven't we, as a board elsewhere? And there are some interesting things in there that obviously colleagues on the operational side are unpicking to know more about. But yeah, thank you, Charlie. That was really great. Good to have with you today, and your colleague as well. Really appreciate that other set of eyes and reflections on it. Thank you.
Thanks very much. See you later, everyone. Cheers.
Yeah. Okay, right. Thank you. Moving on, my chair's report. The only thing I really want to say at this point is obviously there's detail in the report about different activities, what we're doing, and so forth. I mean, firstly, we've had a general election and gone through that. We have a new government. Michelle may say something more later about what that means for us, but you can see in the King's speech certain items are going to be picked up again and pursued, including on mental health legislation. Hopefully, fingers crossed, the offer in terms of the junior doctors will be supported, and in that sense, that's something that we obviously in the last year or so we haven't been as impacted by that as some other organisations in the acute sector, but it still has a knock-on effect in different ways for different types of health services. So hopefully that's resolved. On the local front, in terms of the ICS, there are still massive challenges that we're all aware of, not only in terms of making the money we use work, but also looking at costs in that space as well. And this is as a system, but also what innovation is needed to do things differently. And that's an ongoing discussion, regardless of the change of government. And the only other thing I just want to say, the most important thing, I suppose, in today is to say a massive thank you to Francis and Mike for their service to Humber. This will be their last formal public board meeting. That we will see them. We've got other events with them in the month ahead. But actually, I just wanted to say a massive thank you. Other people on the board have known Mike and Francis longer, but I can honestly say they are exemplary in their commitment and diligence to the work they do as non-executive directors in terms of their committee responsibilities and champion responsibilities and engagement. Both have offered me a huge amount of wise counsel over the nearly 3 years that I've been here. And I was going to say they were irreplaceable, but actually we have recruited 2 new names. But they will never be the same. They will never be the same. They'll be excellent, but they'll never be quite the same as Mike and Francis. And obviously we'll be able to. We're going to make you even more embarrassed at other events in the next months. But Mike, Francis, thank you so much from all of us for your service. You have been, when we talk about improvements as non-executive directors, in your time here, you've seen a lot of changes. and you can see in terms of what's happened, what areas have had to be looked at, how that is the evidence that's provided to reassure you as NEDs about what's happening, both at board and the subcommittees and in other ways as well. And I know you've been assiduous in your focus on that and your contributing to improving the way we work and what we do. So thank you very much. You can clap, everyone can clap, loudly or not, but that's great. Francis, Mike, do you want to say anything?
Just thank you very much. I've really enjoyed my time at Humber. It's been great working with a fantastic team. I think we've seen today with the staff surveys some of the great results the team have had over the last 6.5 years that I've been here, and the culture, the development, the improvement in the quality, the improvement in the finances. It's just a really good board and a really good team underneath them, and it's been a pleasure working with everyone.
Thanks, Francis. Mike?
Thank you so much for those comments. It really does mean a lot. It's been an absolute pleasure to work at Humber, and I've enjoyed my work at Humber very much. Michelle and the rest of the executive team are extremely supportive. They don't take offence very easily, which is good sometimes when I start typing in the evening a bit intemperately. But I'm just so grateful. And when I first joined the Trust, it was in a very difficult place. And there were changes made, including Michelle in particular. And the whole Daily Mail said it's not a wind of change that's passed through Humber, it's a hurricane. Well, I think we've got Hurricane 2 now, and it's changed yet again. So just thank you for those kind words, and onwards and upwards.
Thanks very much, Mike. Thanks very much. Okay. Anything on my report? Is there for noting? No? Okay, let's move on then. Michelle.
Thank you, Chair. Good morning, everybody. And I probably echo the words from the Chair in relationship to Mike and Francis. You'll be sorely missed. And thank you, because we talk about the staff survey, patient safety. We are a team together, and it's a great team, and you've had a great contribution to that. I know we'll say that again, but thank you. Moving on to my report, I won't go through it in detail. People will have a chance to look at it. There are 7 policies to ratify, which we'll come back to at the end. Just to say, it's not actually included, it's at the end of the report. Just a big thank you to everybody that helped and supported me on Thursday last week. It was my annual Chief Exec Challenge. I every year wonder how I get myself into these positions, but then on the day I realised it is great. It was tough. But thank you, Francis, who joined us, Kwame and others who joined me along the way, Karen, etc. Lots of people dipped in and out, but more importantly, the staff that dipped in and out were amazing. Some staff from Westlands joined, in fact, staff from all over the place joined in certain bits. Some did 500 yards, some did half a mile, but it was great. And that comes back to that team spirit and that culture. And obviously it gave me a great opportunity to go around the bases and meet the staff and some of the patients quite a lot of the patients who've done some really great things. If you go into HQ, you'll see some of the great banners that the patients and the staff did as well. I sincerely thank the communication team and Anita, particularly our charity manager, and Pete as well. And I think the fundraising, I think that we had buckets on the day, and people come in, I haven't got any money, but I'm going to give you £1, which was lovely, and it showed the support for the organisation, but also the NHS and the staff as well. So I think at the moment it's about £8,900 that I've raised, and obviously there's still a little bit of time to give, and money is still coming in until we sort that out. But thank you for that. The report mentioned the continuation of some of our awards that we're put in for. So again, that's really good at showcasing some of the work that we do. There's also quite a bit on there around some of the oversight framework and a couple of name changes that we've done internally. So there's little operational things, but I'll draw your attention to them. Obviously, we have had an election. We have put the successful candidates in the paper. The chair and I do meet with the MPs. Try to do it fairly regularly, but we'll continue, I think, to make a real effort, continue to do that, because some of them are new, some of them are what we've seen, who we know before we built up those relationships. So we're working through the Labour manifesto, and it's really clear that they're going to do exactly what's in the manifesto. There's lots of things come out. I'm not going to go through those. I know there's been some fantastic briefings by NHSP, but really about maximising capacity and really upskilling in relationship to productivity. They've mentioned 30,000 appointments more per week. They've mentioned about looking at how we can get patients diagnosed quicker. Is there any capacity within the independent sector to use? But what they are doing is giving mental health the same focus as physical health, which is great. And I spoke to Claire Murdoch and others last week about that, and I do believe the Secretary of State for Health is coming to the region in the next week or so I'll make sure that I'm part of that conversation. There is in the King's Speech about modernising the Mental Health Act, which I think is long overdue. We've all spoken about that for a long time, and that's about addressing particularly the care and treatment of people with autism, learning disabilities, and Rachel and the racial inequalities that happen by the Act. So we'll watch that through, but we have been there before, but we'll watch that through. There's lots of things on the CAS review. They've now accepted that. So we've already one step ahead of that because we've done some papers on that. We've discussed it here. And obviously they're looking at the NHS work plan. So it is in the report, as is a little bit around the mental health. So I'll draw your attention to that. What's also in the report, lots of information. I'm sure you asked questions on it, but I'll draw your attention to the virtual ward. I'm sure Hilary may want to pick something up on that, and that's at section 3.1.3. There's quite a bit on the fuller report around, which I think is quite interesting to look at, and that's 3.2.4. And then the culture of care is a larger section in that report, and I think that links into our own cultural work, which we've already discussed a bit of that on today. Lots of things on people. I'm sure Cam may want to pick some of those up. And then there's an EPR update, which is really important, electronic patient record update. I will draw your attention specifically to paragraph 3.6.1, which is the well-led review, and that's in Stella's report. As you know, as a foundation trust, we have to do a well-led between 3 and 5 years, and this is the external review about the well-led nature of the organisation. There is some flexibility in the timing of that, and if you remember, we did have Grant Thornton in. It only seems a couple of weeks ago, but it was a few years ago now. So we have had some conversation with the chair. We've had some conversations, and there is a section. I think it's about 4.7, I think, in the code of practice. I might be wrong about that. Something around there. So we don't have to do one after 3 years. We've got a little bit of leeway. So we're recommending to the board that we not postpone it, but we wait and we don't do it this year because it was only concluded in 2022. So I'll draw your attention to that section. Usual comms update and usual health stars update as well. But don't forget the policies to ratify in the first section. Thanks, Chair. I don't know if any of my direct colleagues want to mention anything. I've flipped through that, but more than happy to answer any questions. Are you on mute, Caroline?
You're on mute, Caroline.
Apologies. Thanks, Michelle. Any other members of the EMT want to flag anything before I take questions? No, let's go straight to questions. Stuart and then Francis, and then, Stuart, then Francis.
Thanks, Michelle and the team for that very comprehensive report. And I'm really pleased to see that continuing visibility. Very, very, very well done. I've got a question about, probably for you, Lynn, actually, in the section on the new methodology, the brilliantly called Rapid Improvement Methodology for Multi-Agency Discharge Event, MAID, and reference the Super MAID coming up. I know you're going to have this event in August, but are there any indications that this methodology has made any difference, positive or otherwise?
Yes, thank you, Stuart. This is a pretty tried and tested methodology utilised in acute trusts traditionally, and certainly we've participated as an organisation when acute trusts have been holding their MAID events, and as you say, it's a rapid improvement methodology. So it is recommended that it is utilised by mental health trusts. Nationally, that's been part of the sort of one of the sort of high impact recommendations, although to my knowledge, very few mental health trusts have utilised it as yet. So there is interest from other providers as well around how we're doing with this. So we are focusing on actually every patient in our mental health beds in terms of looking at their estimated discharge dates and then examining quite closely their pathway then towards their discharge, and particularly to identify obviously any barriers in relation to that. Now our end goal, or one of our end goals, is to therefore achieve timely discharge of the clinically ready for discharge patients in order to reduce our out of area placements. So I am pleased to say, although we're still in the midst of deploying the methodology, and it will complete in August, Stuart, as you say, with what we're describing as a super-made event, bringing all together the learning from the smaller events that we've had so far, we are already seeing some improvement and some reduction in our out of area placements. What we're measuring is the expected discharge against the actual discharge date for every patient in our beds through this period of time. So we are coming across some barriers and we are able to address those as well. So our system partners are supporting us in this. It's really important that they do, because obviously discharge destinations are often supported by local authority colleagues, for example, some of our colleagues in the VCSE as well. So far, tentatively, Stuart, yes, we are seeing some positive impact, but I will be bringing a full report to EMT, and I will obviously reflect that in my Q updates as part of Michelle's report when we've completed the process.
Thank you, and thanks for that. And it's good to hear that it's having some effect, hopefully. And the reason I raise it is because we're seeing something similar in the specialised provider collaborative. We're also noticing there's a problem in the queuing and the availability of the next phase of someone's care that's holding up people's progress and costing more than otherwise it could do. So thanks for that update. Lynn, I look forward to the progress in the future. Thank you.
Thanks, Stuart. Francis.
Thanks, Chair. Start off with a couple of well dones. Some fantastic work on training in Karen's area and off framework agencies. Some really good work in there. And as we heard earlier on the bank survey, really excellent results. So fantastic. A couple of questions. One was picking up your point, Caroline, and Michelle, maybe with either Michelle or Kwame, about the junior doctors and where we think that's going. Here's my first one.
Kwame, do you want to pick that up?
You're on mute, Kwame.
You're on mute.
It's always happening to somebody.
Well, it's happened to me twice.
Yes, the news that has come out from the BMA is that the junior doctors have agreed a settlement with government, and as a result, the junior doctors have suspended any future actions. As part of their actions when they were on strike, we did make sure that patient paramount, and as a service, we always put arrangement in place supported by operational lead and our silver command, and made sure that patient care never suffered during those periods. But the junior doctors had a settlement and they are coming back. There's no AI actions planned for the future.
Have they actually agreed it yet, or is it being put to them?
The BMA communique said that the junior doctors would accept the offer.
Okay. And they're not going to be called junior doctors, they're going to be called resident doctors. Junior is gone as well. Another shift.
The junior doctors or resident doctors or doctors in training, because any names keep changing.
Okay, second, Francis.
Okay, my other questions were then in Lynn's, but it might be Lynn and or Hilary. So one was around COVID, and because obviously there seems to have been a bit of a spike, which has had a knock-on effect, I think, on which we'll pick up a bit later on staff absence. Just wondering where we were on that. And then to pick up on the point that Michelle raised on the virtual wards, which looks really good. I just wondered if there's any examples to bring it to life of something that's happened, so we can just bring it to life for people. So it's COVID and virtual ward.
Hilary?
I think my hand went up, did it? I did click.
I can see your hands are. I can see it.
It is up, is it? It's just not on my screen. COVID, yes, it is increasing, isn't it? I don't know whether or not it's everybody jetting off on aeroplanes or whatever that's causing it to incubate and bringing it back. But yeah, it's affecting sickness. We've had lots of comms out to staff, lots of reminders about use of PPE, hand washing, etc., etc. And obviously we're keeping a very close eye on it. We have asked, I mean, when we look at the performance report later, you'll see a lot of sickness in our inpatient services. So EMT have asked for a bit of a deep dive into that, looking at causes. Is it long-term sickness, short-term, one unit more than another, comparing with previous years as well? Are we seeing a bit of a trend there? So we are doing some work on that. And then your second question was virtual ward.
And bringing it to life. It does great work. Is there any examples that you've got of how it's working?
I've got a real life one. I went out with the team, and I'm, as you know, I'm an adult registered nurse. Has worked in medicine quite a bit before I came into the management roles. And we went out to see a gentleman that had gone into the acute the day before, spun straight back into virtual ward then, and we went to visit him. And it was just fantastic. The things that we were doing there, we would have been doing in an inpatient acute bed. All the equipment was there, all the tests were there. So it was all that we could do, but we could also talk to the man about the environment that he was living in, you know, trying to reduce falls. We were in his cupboards. He wanted to talk about his diet and his food. You'd never been able to have done that in a ward. So by the time we left there, he'd had a full holistic assessment. You know, his physical health needs, his diet, his risk of falling, his medication. We went through that as well, and you know, advised on what he should be taking when and what he should be getting rid of. He had a lot of old medication in there that he shouldn't have had. You can't do that in an inpatient acute setting, and I was really impressed. Spent some time with him, but he felt when we left that had really made a difference for that gentleman.
That's fantastic. So will we be able to ramp up staff wise enough to, because that kind of service obviously is brilliant, but presumably it's a lot more staff.
Yeah, well, I'll pass over to Lynn then, because that's the upside of it.
Can I just, before Lynn comes in, because I think this is clearly, we could offer a brilliant service and are. One thing came up at a Humber North Yorkshire event yesterday was clinicians, because there's 25 virtual beds, aren't there, or virtual wards available, beds in these virtual wards, that some clinicians are not doing the referrals to them, which is, you know, would be disappointing if we've got this capacity and we've got this excellent service. It's the clinicians referring aren't doing it. So could you maybe include that in your response, Lynn, about what is the actual take-up of the 25 beds, 20 in the ward?
And Caroline, that might pick up on Stuart's comment in the box about 50% usage.
Appreciate that. Thank you. Yeah, great mind, Stuart. There you go. Lynn.
Yes, thank you. Firstly, I'm glad that Hilary told the story that she did. It's a story that she and I have discussed. So back to sort of Francis's first point, this is a really engaged staff team who are really positive about the work that they are doing. And we do get feedback, Caroline, also from clinicians out with the virtual ward team. And there's no doubt this has been a step change, this type of intervention. So the confidence and trust in clinicians to utilise the virtual ward where a hospital bed would ordinarily, I think, has been a learning point right across the introduction of these services nationally and also for us. So our occupancy, we do have 25 beds. Recently, our occupancy has increased. We've been operating at the sort of 70%. It has reduced a little bit in the last few days, which is interestingly. One of the factors for us is that we've only recently recruited the medical staffing element to the service. And that is quite important, in terms of the clinical interventions that the service can provide, but it does unfortunately give that sort of confidence to referring clinicians, particularly when it's medic to medic within the service as well. So we have seen an uptick as a consequence of that. So we are monitoring it very closely. As Hilary said, the patient experience is really positive and we're achieving very good outcomes. And we do a lot of sort of comparing with virtual wards elsewhere. Our ward is a frailty ward specifically. There's other types of wards, virtual wards as well, respiratory commonly as well. So there is a lot of work nationally sort of comparing the effectiveness of these services, but there's no doubt about it, we've got to continue that focus. We do a lot of work with Scarborough Hospital and our colleagues there. So we in-reach into the hospital to achieve discharges, but also the service actually is there to prevent admission in the first place. So it's important that obviously we're working with primary care colleagues, which indeed we are as well. So I think incrementally, the impact of the service is having the impact that we expected to see, but there is more work to do, and it is raised in our ICB. It's part of the UEC work around sort of prioritising and reducing obviously waits in ED and ambulance handover times as well. Interestingly, the ambulance service can refer directly also into the virtual ward too. So I think, but obviously these were new a year ago. So I think they are getting embedded slowly but surely, but occupancy has been a challenge for the reasons that I've discussed, and obviously you've picked up too, Caroline.
Thank you. Thanks, Lynn, for that. Any other questions from colleagues? I can't see any. So we will now go to ratify the policies. I will, for the record, I will go through each one and basically if I don't hear any objection or I just see thumbs up, I'll take that as a ratification. Recruitment and selection policy, thank you. Associate hospital managers policy, thanks. Car parking policy, great. Travel and expenses policy, yeah. Social media policy, grievance policy, and document control policy. Brilliant, great. And just again for the record, Michelle said in her report about the well-led review, and myself, Michelle and Stella, after discussing this, just felt that actually having a well-led external review in 24-25 for the reasons Michelle outlined should not necessarily happen. We obviously will come back to it, but we are obviously still waiting on the cusp of a CQC inspection as well happening too, which we should be due for. But is everyone happy with that? Thank you. Thanks very much. Okay, moving on then to publications and highlights, Michelle.
Yeah, apologies. I've got a wasp that's trying to attack me. So if I'm waving my arms about, please don't get too alarmed, apart from the fact I've got a wasp, which I will get rid of in a second. I won't go through the report. It's the usual policy highlight report. We've got an exec summary of that particular national report and then the relative exec director as commentary. So I'll leave it there, Chair, unless there's any questions.
Thank you. Any questions? No? Okay, thank you. That's noted. We move on now. We've got Catherine with us for item 10, Research Development 6-monthly report, also followed by the refreshed research strategy for 24-26. Catherine, welcome.
Hiya.
Hiya. Sorry for keeping you waiting. Over to you.
Okay, so the first report is my 6-month update report, although this one is a bit more of a look back over 23-24. So I'll just pull out a few key points on the covering the front sheet under positive assurances. Hopefully you can see in the report there's lots of evidence of the impact of research during the previous year. Just to note that our funding for this year has been confirmed. It's as expected. So there's no risk issues there. We also had a positive annual clinical research network, Yorkshire and Humber Clinical Research Network review meeting. They review our performance over the past year and then ask us about some of our plans for this year. That was really positive. In Appendix 4, I've included a long list of all of the studies that were running during 23-24, so you can see the breadth of what we do. They're across all of our divisions and across a huge range of topics. So I won't go through them, but they are there for information. And just something really positive to note, over the past year, we've actually submitted 10 external research grant applications, which is far more than we've ever done before. And that basically shows that we've got clinicians in the trust that are more engaged in research, because to put in research grant applications, we need the clinicians to be involved and to be leading some of that. We're obviously engaged with academics to pull some of that together as well. You don't get research grant funding without having national and international academic expertise involved. So we've worked really hard at that the past few years. And last year we submitted a lot of grant applications, and I can't say the outcome of all of those because some of them aren't known, but we do know the outcome of a few, and it's really, really positive. Some of that information is embargoed, so I can't say it publicly. There are 1 or 2 people in this call that know already about it, but it's really, really good news. So at the next meeting, I'll be able to tell you more about that. We had a really successful 7th annual research conference, sold out as usual. And it was really positive. The networking that was going on in the breaks was fantastic. We've got some really good stuff come out of that. The research strategy I'm going to talk about in a minute. The only main risk, I suppose, to highlight is that from October this year, there is a new provider for the Yorkshire and Humber Research Delivery Network. There's been a slight name change, and Leeds Teaching Hospitals is going to be the host for the Yorkshire and Humber Research Delivery Network, and that's where we get a lot of our funding from. Now, the funding formulas won't change this year, so although there's a change in provider from Sheffield to Leeds in October, our funding will remain constant. But there is, I suppose, a slight risk that from April next year, funding formulas could be changed. I don't expect that there's going to be anything dramatic in the first year, but it's just to flag that. And the only other things in the report I just thought worth flagging was around the conference. I've put in section 6 a really nice quote. We got so many positive quotes and feedback around the conference. And I love this one because it talked about feeling proud to be Humber. And it kind of fits with our sort of one Humber, Humberleavable kind of mantra that we've got now. And I thought that was a really nice quote. And the infographics that I've included in Appendix 1 and 2, they provide a really easy summary of 23-24. I mean, some of the things to note are the amount of people that have taken part in research across our trust, the amount of patients, carers, staff. You know, we've got over 1,500 people that have taken part in the last year. Most people would do it again. All of our GP practices are involved, which across Yorkshire and Humber, about 75% of GP practices are getting involved in research. So actually we're doing really well because all of our practices are involved. And looking at Appendix 2, you can see that almost 50% of the studies, the research studies that we're involved in the trust, involve novel interventions. So this is about completely new treatments, therapies that are being tested within our trust and that people are potentially benefiting from. So that's a run through of the update report.
Thanks very much, Catherine. I think we even had some GPs from and their staff from practices in Doncaster, where I live, over for the day as well, which was good to see they'd made the journey too. Okay, Stuart and then Francis.
Yeah, hi, Catherine. Thank you very much for a very positive report. I really wanted to be able to say what you've landed in terms of research grant money, but I know you can't. That was one of my questions. But so my other question is, it's actually one of the actions you're going to take in the new strategy. It's reference to a commercial research study opened. Can you just elaborate on what you mean by commercial research? Is it patenting? Is it intellectual property?
No, it's actually around working with companies that aren't. So most of our research studies, national research studies that we get involved in, are run by universities or other NHS trusts. They're funded through charitable grants, through National Institute for Health Research funding. And what we haven't done we've not been strong at it at all and haven't done any of it, is the commercial research. So the industry, the pharmaceutical, the medical devices, that sort of thing. And that brings in funding itself.
Yeah.
And some capacity building funding. So it fully funds the research, but also provides extra money for capacity building and brings new types of research. So maybe more drug trials, more medical devices, that sort of thing. Yeah,
and universities are well versed in securing those kind of routes. So if you've got a connection with university research departments, milk them for all they're worth.
Yeah, absolutely.
All right,
it's what we've been doing for quite a few years, is really building on those links and how we become attractive to companies like that. So, and we're getting there.
Good luck. Thank you.
Thank you.
That sounds a really interesting piece of work that's developing there. Francis? Francis, you're on mute.
You have to do it once, as everybody says. Just not a question, just to say really fantastic. We're punching way above our weight as an organisation, which is down to Catherine and the team. They've done a fantastic job. You look at what we've got here, the research conference, the way it all fits into our status as a teaching hospital. I mean, it is really, really impressive. Those infographics at the end are great. They're an easy way to, if I want to go out and talk to people, I've got it there at my fingertips. So just to put on note what a great job the team are doing, and thank everybody for all their efforts.
Thank you, Francis. Echoed by everybody on the meeting today. Okay, thank you. Catherine, let's move on to the strategy.
Yeah. Okay, let me just pull that up. Can I just say, while I remember as well, a massive thank you to Francis and Mike, because I know you probably won't be at my next meeting, and you've been such massive supporters of research across the years. And I remember sitting in a room with Francis quite a few years ago talking about money and how we can make this self-sustaining and bring in money and things. And that was really, really helpful. And I think we've moved on quite a bit from there. So thank you, both of you. You've both been massive supporters. Right, research strategy. So the front cover sheet probably says everything that I need to say about the strategy. It's overdue, really. We should have had a refreshed strategy in 2023. But the research conference, where we were going to do lots of consultation, had to move to virtual because of COVID rates. So we couldn't do all our consultation. So we've postponed that, and we did a lot of road shows in the spring. We were also waiting for the ICB, the new Innovation, Research and Improvement system of the ICB, to produce their research strategy, but they're now not producing anything until later this year. So we were sort of hanging off for that so that we could incorporate some of that into our strategy, and obviously the consultation. But we are where we are. We've refreshed the strategy. It has been through QPAR, CMT, Quality Committee. Most of the strategy remains unchanged. It is a refresh. We've taken into account things like new performance indicators, different ways of working since COVID, because our initial strategy was produced just before COVID. So there's different ways of working now. I've on the front sheet, under decisions made, I've actually listed all of the changes so that you could see what I've actually changed in the strategy. So I don't know whether you want me to go through those or just accept that you've seen that, and if you've got questions.
No, thank you. That's a nice framing of what's happened with this, Catherine. I think it's really helpful. The front sheet's really helpful, actually, in being really clear about what has changed, because that's nice to know sometimes that it'd be pulled out for us to know what wasn't there before and what is there now. So I appreciate that. And it's gone through various committees. So if there's any questions from colleagues, no, I think people are happy with what you've said, but also the process that's gone before it. Is the board happy to ratify the refresh strategy? Yes. Thank you very much, Catherine. All the very best to you and your team.
Thank you, everyone. Bye.
Okay, let's move on to the electronic patient record. Lynn.
Yes, thank you, Caroline. So I think the key issues similarly are covered on the cover sheet. But we have increased the frequency now of the EPR programme board, obviously as we get closer to go live for the first division, obviously, which is forensics, as you are aware, in September. We have now released the e-learning package, so slight update from the cover sheet. That's been tested by a number of staff, including clinical staff and administrative staff. I've literally just received some feedback. We'll be looking at that at the next EPR programme board on Monday, but the feedback in terms of the quality, accessibility of the training looks really positive overall, but we will have a look at that more closely. We have established a training task and finish group to ensure that all the divisions have robust training plans. Those plans have been completed now as well, so we are satisfied with those. We have commenced the data migration. Obviously, it's a manual data migration for the first division forensics. We started that a little earlier than planned, and that's going well so far. So overall, we are on track with the programme plan in terms of where we were expected to be at this point in time. The risk register is also there for information as well. There was an outstanding business process change that we have now completed the mapping for. That was around waiting time specifically, so that has now progressed otherwise, Chair, just really happy to pick up any questions, and obviously it was helpful having the external support from the colleague who talked to our board a week or so ago now, in just that compare and contrast with other organisations who've been through this process.
Yeah, thanks for mentioning that. It was really helpful and constructive. Francis.
Yeah, just to pick up that we had a really detailed discussion about this on Thursday at FIC with Lee, who talked us through all of the feedback from the two sessions we had, the one recently and the one a while ago, and talked us through and gave us really good assurance that we were picking up all of the learning from that if we hadn't already doing it anyway. The only thing we didn't see was the risk register, but we were very assured with the way the process is going to date.
Thank you, Francis. Phil?
Lynn, I just wonder if you could just provide us a little bit of insight how we've managed to reduce the risk scores from 16 to 12 on the data migration from Lorenzo to System 1. I was just a little anxious that we're the first trust to do it, because you're never the first when it comes to digital. So I just wondered if you could just how have we managed to reduce the risk down?
I guess, Philip, it reflects the risk that I raised here at our last board meeting, where we had tested the robotic process and it hadn't quite delivered to our expectation. Since then, we've obviously looked at the position. We've now made a decision that we're going to take a hybrid approach, as you were aware, and that we've recruited and continue to recruit sufficient data entry staff to manage that position. That's what's led to the reduction in the risk. But obviously, data migration does make us all very nervous. So we will continue to monitor that position really closely. We've also had that slightly extra time as well around the migration for the forensic service, and testing of that so far is also looking really positive. But we continue obviously to be vociferous about that, Philip, for the reasons that you're raising.
Thank you.
Okay, thank you for that. Priyanka? You're on mute, Priyanka. You're still on mute.
Right, sorry about that.
So,
thank you, Lynn, for that. And like yesterday, I logged myself in to ask about EPR, which was conducted by one of the group, and I was very happy to see that there were like a lot of important questions asked, and the lady who was delivering the session, she wasn't sure of some things, and then she did take a lot of questions back with her her. So I was just, and also only I was a bit concerned about one of the things that she said. I said, oh, this system is a very logical system and everybody, it would be easy to use, but you'd be amazed, knowing from past experience when it's digital, when something that's logical to one person is not logical to loads of people. But I was happy to see that those questions were put forward, and I'm hoping that they would be answered. The second point that I would like to make is that there was only quite a low number of people in this session, and when I asked at the finance committee whether we had any numbers of the uptake of the training, Lee said that it was not available yet, but it will be available in the future. So it might be a thing to look at about the uptake of in numbers. Thank you.
Yes, can I come back on that if that's okay? So we haven't commenced the training yet, Priyanka, but as soon as we absolutely do, it will be one of the data sets that EMT will be monitoring very closely. As SRO for the programme, I will be making a recommendation in terms of whether it's stiff to proceed with go live, and one of the key measures will be uptake of training. Not just the uptake though as well, but obviously the feedback that we've got from the training, which is why the feedback that I've just provided on the testing of the training is really important as well. So far that's looking very good. So, but we will be monitoring that very closely. Obviously, there's been a variety of information sharing sessions. So I'm not surprised that at various events, the uptake by staff of those is a bit variable. But obviously, this is being managed very closely through the divisions as well. There's a specific digital group that's overseeing that on a division by division basis. Also, it's not just going to be e-learning, although e-learning is the key method of delivering the training. We know that some staff, for various reasons, will find that difficult to access. So there's a blended approach to learning where some of it will be classroom based and some staff will actually be identified to have specific support with their learning as well. So I think we have got a good, robust plan, hence why we've got a training task and finish group, but we'll continue to monitor that area very closely.
Yeah, I think having the cumulative totals on these things are really helpful as well, so we can real time. Thank you, Lynn.
Thank you, Lynn.
Okay, I don't see any other questions up. That report is noted. Now I'm going to jump forward now to actually to Tracy, which is she was Flanagan, because she has to be at meeting join another meeting at 1:45. So Tracy, are you with us?
I am with you. Thank you, Chair, and thank you for moving me forward. That's much appreciated.
You're welcome.
Thank you. So I'm here to talk through the 6-month review of our safer staffing performance. This is part of our 6-monthly reporting cycle. Hopefully people are familiar with the format of the report and the purpose of the report. It includes a review of 6 months performance data in relation to safer staffing, so things like our fill rates and our care hour per patient day, but other quality and safety measures that we look at monthly on our safer staffing dashboard, but then also as part of this reporting, we pull together a 6-month review, and this covers a period from October to March. We then conduct a series of safer staffing reviews at a team level, and we've managed to do most of those face-to-face this time round. Couple of exceptions where we've done that on Teams, and at those reviews we have members of the senior leadership team from all of the teams, the nursing, members of the MDT where we can, finance, colleagues from e-roster teams, and we look at their performance data, but we also review dependency data which the teams collect over a 21 to 28 day period. So it looks at the level of dependency for each individuals that they have on their units, and that allows us, where we have validated tools, to then calculate the number of whole-time equivalents they need, and to recommend a level of care hour per patient day. There are some caveats with that. So some of the units don't have a validated tool that we can use, and some of the units are smaller than the recommended size of units that the tools can be used with effectively. And in those instances, we still have a discussion with the team. The dependency data is really useful, and as we're capturing it now on repeated 6-monthly reviews, it allows us at least to see some trend analysis and have a discussion about any changes. So this round of reviews we've actually as well completed with our Band 6s, Band 7s and our modern matrons, training around the use of the MHOS tool. So this is a tool that we use in mental health services. We've been using it for a while, but we have now undertaken the inter-rater reliability, which gives us more assurance, I guess, that what we're the outcomes from the use of the MHOS tool can be more meaningfully interpreted, and we know that there is that degree of consistency in terms of how staff are seeing dependency, which is really important. So I think it's really, for me, important to acknowledge at this point that the level of engagement and the ownership and the understanding that the teams are now demonstrating in relation to their own performance data, in relation to the methodology around how we collect the dependency data, how we use the tools, has really come on leaps and bounds. I think some of the language, the tool itself looks a bit daunting, but we, across the board now, we're going into these reviews and the teams are really well prepared. They're really conversant with what we're talking about. They contribute to the conversations in a really meaningful way, and that allows us to make much more meaningful and rounded recommendations about both the establishments and the recommended care hour per patient day. So following the reviews this time, we agreed that all areas had achieved good assurance, and that's the first time we've been in that position, and that is great to see. And that doesn't mean we're resting on our laurels at all, and obviously there is still some details at a team level that we need to sort of like pick up, and we're constantly striving to think about how we link in with NHS England, for example, to make sure that we're maximising the opportunity to use the benchmarking data that we have nationally and emerging tools to help us to make sure that we are confident about that level of assurance that we're seeing and describing. From a care hour per patient day, all our units are achieving their target and exceeding their target, with the exception of Malton. Malton is in terms of Malton, as I've alluded to, because we don't have a validated tool that allows us to look at a recommended care hour per patient day. We have sort of struggled really to think about what a meaningful target would be. There is some national benchmarking data available through the Model Health system, but there's only 3 other community units that contribute to that. So we're not confident about the validity of that data. And so we're going back to NHS England to have a conversation about what tool they would recommend. So there's a tool that's used in the acute trust, and it may be that we can use the older adult module in that tool, and that would be a more appropriate fit with our community wards. But we're going to agree that with NHS England, and that will hopefully allow us to establish a target for Malton that is more meaningful. Because at the minute, although Malton aren't meeting the target, we're not sure really whether that's of significant concern for us, or whether it is just that target can't be usefully validated at the minute. And in terms of how we continue to benchmark both regionally and nationally at an organisational level, we continue to outperform other organisations. We continue to have a strong performance in the upper quartile. We do exercise a little bit of caution with the ward level benchmarking, because as we've described in the report, sometimes we're not, for example, with the forensic benchmarking data, they don't differentiate between the different types of wards, low secure, medium secure, high secure. So there's some caveats with how we look at that benchmarking data, but organisationally we continue to be very strong. I think there's obviously at the front sheet and in the body of the report, there's a breakdown at a team level. You can see the sort of like the progression over the subsequent reporting periods to this reporting period. I think in summary, it's really important to reference the fact that we did an internal audit last year, and that provided strong assurance around our processes in respect of our governance around safer staffing. I think we can see that good assurance across the board, which is really pleasing. I can't emphasise the importance of that engagement of the teams. it's a when you first start looking at some of the language and the tools we use in Safer Staffing, it can be daunting, but they've really embraced it. And I think that ownership and that understanding of their own data has really grown and strengthened, and that's really heartening to see. It was really lovely to hear a lot of feedback in our reviews of the teams about the TNA roles. And now that they're qualifying as nursing associates, what that's meant in terms of that contribution that they can make to the Safer Staffing establishments, but also the growing our own and the retention of our staff and that investment in our staff, which we're now starting to see really come to fruition. So that was great, and several teams mentioned that. Following the discussion with the report at EMT, we have agreed that, as I think Hilary was alluding to earlier, that we will do that deep dive into sickness in the inpatient units, and we'll work with Karen and Karen's team in terms of understanding some of the factors that are contributing to that. And we still know we need to do a little bit of adjustment. We've got into a really good cycle now with the units, in that we're doing our dependency data collection within the same time window. The reviews are all scheduled, so they're aligned to the 6-month report coming out, and so we can share that data with them. We just need to do a little bit more in terms of adjusting that to fit in with the budget setting cycle and the workforce planning cycle. But yeah, happy to take any questions, comments. Thank you.
Thanks, Tracy. Appreciate that full report. Thank you, David.
Thank you, Caroline. Can you hear me better this time? I've switched microphones. Is that okay?
Yeah, that's perfect.
Tracy, thank you for a superb report. Lovely to see you again. I've not seen you for some time. Just a couple of questions. On the care hours per patient day, we're benchmarking really well on that, and it's looking great. In fact, it's great to see so much green on the report overall. But we're benchmarking really well on the inputs that we're putting into it around the staffing. Are we able to correlate that with outcomes? So can we compare with other similar benchmarkable trusts to say that because we're putting in these extra resources more than others are, we're delivering much better outcomes for our patients?
I think that's a really interesting point, and the model health system does have other benchmarking data that we could look at. It's not explicitly aligned to the care hour per patient day, and I think internally we've looked at what does that mean. So we're scoring well, we've got strong care hour per patient day, but what does that mean? And that's where we have included those other quality and safety indicators so that we can see what impact that's having on things like our training and supervision and appraisal, but also in terms of our incidents, the incidents that we're recording. So I think there is something within the model health system that we could draw out and make that more global comparison. I think that's a really interesting point, David. Definitely something we could consider. Thank you.
I think outcomes are really important for what we put in, and I think across the ICS, outcome-based funding is very much a topic of conversation, which I'm sure Stuart might want to say something. Francis, sorry, I missed you there. I should have brought you in there first. So to Francis and then Stuart.
No problem. It was just to pick up on the sickness that you're doing a deep dive, which is great, because if you look at it, it seems to be consistent. There seems to be some very, very high sickness levels in there. I was just wondering if that work would come back to workforce as well as EMT for a discussion at some stage.
Yes, I'm sure. I mean, Karen's put her hand straight up, so I'm presuming that Karen will be saying yes, absolutely. It needs to be covered. It needs to be considered, doesn't it, from lots of different perspectives, and the understanding that we have and the sense we make of that deep dive will have an impact not just for Safer Staffing, but much more widely.
Thanks, Francis. Stuart.
Same question actually, but have you got a working hypothesis about the deep dive into sickness, about what you might identify?
Karen? So I'm conscious that Karen's got a hand up. Karen.
It's all right. No, I said Karen. Karen, do you want to come in on that?
I'm happy to come in on that. So I think at EMT, we did make that correlation a few weeks back when Hilary first brought the report in terms of some of the key indicators for high level sickness in those inpatient areas. Those of you that attend Workforce and OD Committee know that we already do a deep dive analysis into sickness already, but what we have already realised and commissioned as an EMT is that we need to look much deeper into what that sickness absence looks like in those operational areas particularly. Now, it's a very broad question you asked, Stuart, so at this stage I probably can't answer it in too much detail, but what we will be looking at is what are the reasons for the sickness in those areas, so that we can look at addressing what the root cause might be. So it could be that, and we know that stress particularly is the highest reason for sickness absence in the organisation. We'll look to see whether there is a correlation particularly in those areas, and what we will then look to do is put the right interventions in those areas and the solutions, whether that's through HR or otherwise, an OD, to start to really tackle that. And the other thing that EMT have commissioned is a deeper dive and some greater influence around return to work interviews. We know that people who have a good experience coming back to work are likely to maintain positive attendance in the workplace, and there's a big piece of work around that as well.
Thank you.
Thank you, Karen. Any other questions to Tracy? No. Okay. Thanks very much, Tracy. Hope you've got a breathing gap before your 11:45.
Thank you. Thank you very much.
Take care. Okay. Right. Can I just check in something on the gender pay gap and equality delivery system? Are you presenting on that, Karen? It's just you, is it?
Yeah.
Perfect. Lovely. Because what I'm going to suggest is we take a 5-minute break now, and then we come back after that to give everyone a little bit of a breather. Thank you. Okay. See you in 5. Welcome back, everybody. In the break, I've just done a bit of a reshuffle, and as we've got our colleague Alison Flack here, we're going to take items 20, 21 and 22 on the agenda. And with Michelle, we start with the Humber and North Yorkshire Health and Care Partnership, Mental Health, Learning Disabilities and Autism Collaborative Programme update. Michelle, Alison.
Yeah, good morning. What I was saying, I'll obviously introduce Alison, the programme director, just give you the usual customary update. So that's about it from me. Over to Alison.
Thanks, Michelle.
Thank you, Caroline. Morning, colleagues. You've got in front of you the recent update from the Mental Health and Learning Disabilities Collaborative. I wasn't going to go through the whole paper. I'm hoping that colleagues have had a chance to have a look at it. And there is a summary on the front sheet and also within the paper, but just wanted to pick out sort of the key issues and the work that we're on with at the moment. You'll see that quite a lot of the time has been spent in planning, looking at our forward trajectories for the year, and also the level of investment and the additional funding that we've received through the Sustainable Development Fund, which is known as the SDF. So it has been slightly delayed as the ICB have been sorting out their finances. So we're currently working on our plans to develop the SDF funding, and that's broken down into the main sort of national priorities around children and young people, perinatal, dementia, and the National Inpatient Out of Area Programme. There is information in the paper about performance at the end of last year. We are now focusing on this year, but just wanted of note last year to note that we did meet the children and young people's access target, which is really good news. And we are now starting to flow all of the data from the voluntary sector providers as well. So that's great to see. And we also saw a significant increase in the numbers of serious mental illness physical health checks that were undertaken. And now we've got a really focused piece of work looking at the quality of those, which I think goes back to the conversation that you were having about outcomes previously. We're also starting to see there's been a lot of work in this area, the dial changing on the dementia diagnosis rates. Already in the first 2 months of the year, we've seen an increase in some of our places on that. We've got a huge sort of data cleansing project underway, which we're doing in partnership with primary care, which is certainly starting to see some of the results. And we've also been able to look at allocating some of that SDF funding to look at dementia diagnosis rates, sort of wait times and the treatment pathways. The 3-year National Inpatient Transformation Plan is a big programme of work that we're working very closely with Humber and our other providers on. One of the focuses on that is around making sure that we have sort of identified all of our patients that are currently out of area with a view to being able to bring them back, but also to develop new services to stop people going out in the first place. So that is a huge programme of work, focusing not just on making sure that there is significant savings to be made, but also on the quality of that, how often people are being seen, and working much more closely with the independent sector. So we did submit our report and the plans, and we're currently working developing that. And I know that Humber have submitted a proposal against the SDF funding to develop more older adults services. So that's really good to see. So the other thing that is a big project at the moment is developing what the future model of the collaborative looks like, and the ICB's intention to devolve the commissioning and provision responsibility down into the collaborative. The mental health chief exec providers have been working closely together on this, and we're just sort of waiting for some clarification from the ICB. And I don't know if Michelle wanted to say anything else about that. She's shaking her head no. So more on that as we progress sort of through the year. So that's the high level summary. Happy to take questions and comments from colleagues. Thank you.
Thank you, Alison. Stuart.
Hi, Alison. Stuart here. I have a question, Alison, about it's the section on mental health. What's the performance section? And there's a paragraph which left me slightly confused about it said the reduced performance for talking therapies from the previous year is 195, and it suggested that a transformation program had led to a worse result. Is that the truth? And then secondly, the metric of performance has been moved to an outcome measure as opposed to something else. Can you just comment on that, or did I misread the paragraph?
No, it's probably the way it's been written, but Talking Therapies is closely aligned to all of the work that's happening around the transformation of the community mental health teams. So different routes of access for people.
Yeah.
But one of the outcome measures that's been changed that we had last year was measuring access, whereas we're sort of moving much more towards measuring outcomes and improved outcomes for patients. So that's the issue about the metric changing.
So less emphasis on the flow of people through the channel, but more as a result of whichever channel they've gone through, did they get the care they need, or did they get the result they need?
That's correct, Stuart, but also sort of much more focus on the outcome around recovery as opposed just to the access target. And I mean, we're performing well from a Humber perspective on that, but obviously the redesign of the community teams still needs to see that ongoing transformation.
Yeah, thanks. And then
maybe that needs rewording a little bit, I think.
Yeah, well, you'd left me a little bit
because I agree with Stuart. I took
Yeah.
something else away from that.
Happy to
it wasn't transformative, Stuart.
And then the other thing is that the reference to the funding, the two chunks of funding. I mean, we know because we've seen in our own finance committee that the ICS as a system is under financial pressure. As far as you're concerned, are those funds kind of upper bottom guaranteed, or are they working assumptions?
Well, the SDF, and I'll maybe refer to Pete as well in respect to this, but we have had that, we are developing our implementation plans for that 6 million, that first pot of funding over 2 years. Yes. And we're getting sort of finalised plans, which we hope to have by the middle of August. I think we're working on the assumption that that money is in the bank and that we'll be able to deliver the services. But as you say, the ICS is under significant pressure around its finance. Yeah, I don't know if Pete wants to confirm what I've just said there.
Yeah. Before Pete comes in, is that all of the money as well that we could access? So not only have we copper bottomed that, but is it all that we're available to get?
So on that question, Francis, it's not the full allocation of mental health SDF that came into the ICS, it's a proportion of it. You know, we're working on the basis of, as Alison said, is that funding is committed and ring-fenced and therefore shouldn't be subject to any, I'm going to use the word clawback because I can't think of a better explanation. But, you know, if we're all a realist on the call, we're aware of the wider financial pressures in the NHS and the ICS already. So that does remain a risk until it is actually, I'm going to use the word contractually committed, which that's what we're working at pace on at the moment, isn't it, Alison?
Yes, yeah.
Perhaps that should be reflected in the key risks then.
And we can certainly update for that, Caroline.
Yeah, sure. I know we've got it elsewhere in other documents and things, so we're aware of that.
I think it's important to flag around that money because, for example, the developments that we're putting in place to bring people back or develop new services for out of areas is in effect an invest to save scheme because we will reduce how much we're spending on sending patients out of area.
And I think on that one, Alison, we're very much referring to it as pump priming out, where we expect what we use the SDF for will actually be then made available. The SDF would be remade available next financial year because we start to see savings in out of area spend.
Yeah.
Okay, thank you. Francis, did you have another question?
Yeah, two on dementia and one out of area. So on dementia, obviously we're at Drift. You've got in there about a maternal mental health business plan. Is that going through and what impact will that have?
Yes, so the maternal mental health business case is going through. So we're just developing what that's going to look like across the ICS and what potential contractual models we might use. And we're having conversations with Lynn and colleagues about that. Once we've got that established, that will impact on the perinatal access rates. So we would expect to see those increase. Although we have, from a Humber 4 perspective, we will meet those, but it's the other bits of the geography where we haven't. And the dementia, what was your question on dementia?
So that was the first one, and then the second one I've got was on the fact that the ICB is well away from the target. How do we compare to other parts of the country in terms of that?
I think in some of our places we're performing quite poorly. So if we look at York, is one of the lowest dementia diagnosis rates. I think from a Humber perspective, and if you compare us to other ICSs in our region, then we've got similar comparison. But I'm absolutely confident that we're starting to see that increase in because of this work that we're doing around the data cleansing.
Okay. Maybe again we can see in I was going to say maybe again in future reports we can see a little bit more benchmarking.
Yeah.
Yeah, happy to do that.
And then my final question was on out of area. We're changing the metric to inappropriate out of area placement. Is that a fudge? We're suddenly going from all to only inappropriate. I'm just trying to understand that.
I think what we're doing is changing the metric because it's always been counted on occupied bed days as opposed to number of patients. So we're not changing that these people are inappropriately placed. And we've also had to look because originally people were seen as being inappropriately placed if they were outside of, if you like, their normal local services, whereas now it can be outside ICS footprint. So there's still a bit more work to do around that and the definitions.
I'll just be a bit dubious if we suddenly see a massive improvement because we changed it. And have we got any historical data to compare it against? That's all.
Yeah, we've got an awful lot of historical data, and we've now got what we've got now is like a monthly dashboard that's looking at how many people have got placed out of area by the different specialties, by place, but also how many of those are clinically ready for discharge, how long is it since they last were reviewed. And that's part of the work that I talked about that we're doing in partnership with the independent sector providers to make sure we know where our patients are and what the discharge plans are for them. So there's that real quality aspect to it.
Okay.
Happy with that, Francis?
Yeah.
Okay, thanks, Michelle.
Yeah, two things. The dementia diagnosis, we do benchmarks. We've got a performance report that shows the dementia diagnosis across the region. It's a really complicated performance report, but we could pull out things and share that with the board. It does get really complicated how they look at it. It's slightly different to what we've seen, but we can use that. In relationship to the inappropriate, we've always used a bit of that phrase in terminology, Francis, but I take your point. We're trying to get more in allegiance across the board with what other people, how other people classify and put down in relationship to out of areas from the criteria point of view, etc. Because that's how we're building up this out of area dashboard, so that when we've got more rigor and grip on the out of area placement, because I would say that you can argue that all out of area placements are inappropriate. It's just a terminology that we use in relationship to it, but I do take your point on that. So I think we're getting more rigor and grip with the dashboard that we've got. And that being overseen and managed by the ICB, but also linking into the providers. But what it's also allowing us to do is compare properly, or a lot better now, our position as an organisation with the wider sector, which was a bit out of kilter, to be fair. So, and we have got a lot of work now going on in that work stream in relationship to out of areas. One, how we can redefine the whole process and the flow, but also how we manage them, because what was really clear is that the ICB didn't know where some of these patients were. They may not have come from our organisation, but they didn't know where these people were. So this is the ICB paper that we're looking at. So I think we've got a lot more rigour and a lot more control on it, if that makes sense. But I do take your point about language, and we'll have a conversation about that.
Thanks, Michelle.
Thanks very much, Michelle, for that. Okay, I don't see any other questions on that, so thank you. That report is noted. Can I just, on the next two report, just go straight to questions, if that's all right, and comments?
Of course.
And then I'll let if you want to add anything, Alison, that's brilliant. So on the first one, on the Freedom to Speak Up Guardians annual report, are there any questions or comments on this? No? Okay. Is the board happy to approve that paper? Perfect. Thank you. And the Freedom to Speak Up Strategy 24 to 27. Any questions or comments on that? No? Is the board happy to approve? Yes, that's great. Just to say, Michelle, Dean and I with Alison had a really good catch up, our quarterly catch up yesterday. I just want to put that on there. And I hope it's okay, Michelle, if I just say our strategic board meeting in, let me get the date right, September, I think, October. We're going to invite our Freedom to Speak Up champions and obviously Nikki and Alison to join us for lunch that day. You know, we tried to meet clinicians and staff during that period, and that will be part of the Freedom to Speak Up month as well. And there's lanyards being developed that are going to have Freedom to Speak Up on them as well, which will be launched soon as well. So we're really pleased about that. So I just wanted to flag that to everyone as well. So thank you, Alison. Appreciate your patience today.
Thanks, everyone. Bye.
Okay, thank you. Fine. So those items are approved, strategy approved. I should have said earlier, Tracy's report on the safer staffing levels. Is everybody happy to approve that report? Brilliant, great. Just for the record, we've got that down. So we'll move on now back to the social values report. Again, can I just see if there's any questions on this to Kwame, please, or comments? I really like the style of these reports that we're getting into, actually. I thought last year's was great, and I really like the style of this. So David and then Stuart.
Yeah, thank you, Caroline. Great report. I spent most of my life working in charities who do a lot of this work, and many will be very envious of the breadth and detail within this report. Two questions. I think it's similar to what I asked last time, actually, about kind of what we're going to do with it. It's a huge report, contains lots of great stories, so how we're going to disseminate it. And then a specific question. On page 2 of the report, it tells us that we had 446 hours of volunteering, which I'm sure can't be right, because I think our volunteering team were paid to do more than 446 hours to look after the volunteers. So just to kind of clarify where that number comes from.
Thank you, Kwame.
So we normally do a lunch, and then the lunch, for one of the things we're doing with the annual members.
Hello?
18.1. So we use every forum in organization, including ComComs, to disseminate and make sure that the report has a good impact. Yesterday we met with CQC as an example, and we agreed that we will send a report to CQC for them to see all the work that we're doing. So we take every opportunity, including AGM, to give
Are we
a
doing
lot
any
of
external
impact
publicity with local media and radio, for example? There's lots of stories in here, I would have thought. Is that part of the comms strategy?
We haven't talked about external using local media and things like that, but I think that's a good suggestion. Like what we did last year, we took all the feedback. So if one of the feedback, I will discuss it with our comms team, and then we can take that forward as a strategy.
Okay. And the question about the volunteer hours?
Shall I come back to you? I'm not too sure of the figures, and I don't want to give you any figure in terms of the output. It seems low. I haven't looked at it again, so I will check it and then come back to you.
Okay, can you let all the board know that, please?
Yeah.
Thank you. Stuart?
So I might be a bit of a detractor here. So I really like this report, but I feel it needs to be strengthened in terms of its either conceptual or philosophical approach about what we mean by social value, because many of the examples are what we do as our core business. Now, you could argue with everything we do has got social value, but that's a bit kind of circular, isn't it? So I feel at the front of the report, and I can maybe take it outside the meeting with you, Kwame, I think there's a bit of crispening up of what our methodology is. And then there's a couple of things where I think there's some typos, like this, it refers to 22-23 as opposed to 23-24. Just want to make sure we haven't got that right. And a couple of the examples are quite low key compared to others. We could do a lot more about carbon reporting. So maybe what I'll do is provide some comments outside the meeting. But I think some great examples. We definitely have this impact wider than healthcare. But I think we need to frame the report in a slightly more, well, I'll call it sophisticated way, actually.
Thank you for that. Any other questions or comments? Francis?
Yeah, I agree completely with Stuart. So if Stuart feeds back that, great. And then mine's a very, very minor one, but on page 16 4, there is a comment on the green focus from Sarah Locker, Service Manager, and if I'm not mistaken, it's a picture of Karen.
Pete spotted that this morning, so thanks for pointing that out, Francis. I'm going to pick that up separately.
There's no picture of me in it at all as chair, but there we go. Yeah, thank you for pointing that out. Great. Anything else, Francis?
No, that's it.
Thank you. Michelle?
Yeah, no, thank you. And thank you, I noticed it, and I missed it the first time, and Karen, but I noticed it last night when I did a look at my papers. But anyway, that's absolutely fine. A good picture. But we will sort that out. Just getting back, I think, Stuart, any comments like that really will be really gratefully received, because this is an iteration document and it's getting better every year, and not all organisations do this, and I felt really strongly that we needed to demonstrate and show what we did in relationship. And it started off as everything that we did that we weren't necessarily contracted to do from the financial point of view. So it was a bit about, we talk about added value, added outcomes, added benefit, that we drive in relationship to the community and the communities that we serve. So it started from there, which is why there's some rough financial stuff in there, which I know you teach with a bit of a health warning. So I think anything from any of the board members, particularly the non-execs, that we could look at for next year would be really great, because I know this is getting a lot of national attention, because there isn't many trusts that do it in this layout and what have you. So and obviously I'm taking it positive too. I think it's some really good comments, and I think you're right. We do need to maybe define it a bit better on the front, because we know what we're talking about.
It's that framing piece, and there's quite a lot of material emerging about how corporates of various kinds report on those. Well, it used to be called ESG. It's going beyond that now, the added values and so forth. And even if what you just said was articulated at the front, it would give it a bit of a framing that I couldn't see at the moment. So I'm happy to comment in detail on the piece. Yeah.
Because obviously we live and breathe it, so we know what we forget that. So I think that's what's really, really important, that you can feed that back to us. But no, that'd be really good. Thanks.
Okay.
Yeah, I think it's sort of in some ways, isn't it, linked to having a plan for external communication, and not just to people in the NHS who are in the know. And if you have that in your head, you start thinking about, well, does it say on the tin what's in the tin? And I think that's what's really probably is partly your point, Stuart, is about, what does it mean to someone picking this up or seeing it online or whatever in that circumstance. So I think from that discussion, there is framing, which I think Michelle has practically given us a framing, which is really helpful. And any other comments from Stuart or others to feed that in maybe to Michelle and Kwame on this. I think there's some proofreading need to be done to make sure it's accurate and the right photos are next to the right people. And I think there's a question about the volunteer hours. To be honest, are they accurate and is that good? I don't know. Is that good? I know we've talked before that actually we need to boost the number of volunteers we've got, because I think we felt they were pretty low in certain areas. So, there's something in that as well. And then I think the fourth thing is where's the external comms strategy for it, apart from just the annual members meeting and to CQC. It's a lot of work goes into these things. It's sad if actually they don't have wider impact and relevance to people. So yeah, Michelle. So that's, I think, takeaways from that. Michelle?
We have got a detailed comms plan, which is why we're going to launch here at the AMM, but I will send that out as well. Because we've not done that as much in the previous years, to be honest. So I think we are getting better with how we do send it out and what have you. So.
Yeah, and the different ways in which you can do it as well to get the message across. But I think that's really important given all the work that goes into it. Right, okay. Is board happy to approve with those sort of comments back this social values report?
The report, it needs the typos correcting before it's approved. But once the typos are done, then yeah.
Subject to the caveats I summarised just before, yes. They'll be held to pay if a typo goes out now. Okay, right. Thank you very much. Let's move on then to the gender pay gap, Karen.
Yes, so I'll keep this really high level. So I know this has already been endorsed by the Workforce and OD Committee, so it's been seen by a few, and it's obviously been approved by our executive team as well. So introducing the annual pay gap report, which is in response to the request for upload of to the national data set with a snapshot date of the 31st of March 2023. It is really important just to note that this isn't related to unequal pay, but the difference in average pay between males and females. So in terms of some of the key points from the report, so our trust pay gap is at 12.4%. That's been an improving figure for a few years now. In 2022, it was 13.2%, so improved on last year or the year prior. We are reporting a better figure than the national position as well, which is currently 14.3%. I won't go through the actions, but I know that you're quite well cited as a board in terms of the EDI actions. So actions are on page 12 of this particular report, but they are then embedded within our EDI updates as well. So you will become familiar with any new actions as we proceed. So I'm just happy to take questions.
Thank you, Karen. Any questions to Karen? No, we have actually sort of discussed some of it. It's been to different places already, hasn't it, Karen, as you said. Right, is board happy to approve this document? Yes, thank you very much. NHS item number 15, equality delivery system. Karen, do you want to just give a quick?
Yeah, absolutely. So again, this is a national return that we complete, and what it is a really good demonstration of the work between John Duncan and Mandy Dawley, particularly around the EDI for both patients and workforce. It shows our evidence against 3 domains, again, across those 2 specific areas, and our progress. And we're asked to rate ourselves in terms of whether we're achieving, excelling or developing. So we seem to be progressing really well. Again, I don't think you'll be surprised to see a lot of the content within there, because again, the board are quite well cited around particularly the workforce actions that we take over a period of time. So again, it's just to open up for any questions.
Any questions? No, thank you very much. Happy to ratify, board, please. Yes, thank you very much. Thanks, Karen. We move on to the finance report, Pete.
Thanks, Caroline. So this is the finance report at the end of Q1. Just to remind members of the board that we have a break-even plan for this financial year, but that plan is dependent on some income in the second half of the year that we were asked to assume from the ICB. You'll see within the report that we are on plan at month 1 and we continue to forecast a break-even position. But the 2 areas where we do have an increased focus at the moment are the mental health division, where they are working on a recovery plan at the moment to improve their forecast, and we continue to have a strong focus on agency spend, given the lens of the ICB on workforce, and that comes to EMT on a monthly basis as well as ODG and divisional ODGs. You'll see within the report our better payment practice code and cash position remains strong, which is a good indicator of financial health. I am conscious of time, so I won't go into too much detail. I'll stop and see if there are any questions. Thank you.
Thanks very much, Pete. Any questions to Pete or comments? Mike.
Thank you, Pete. On the mental health recovery of the budget, a year or 2 ago, I was drawn in on about the underspend in mental health caused by the number of vacancies primarily. So it's starting to make me think, is the budget correct on that area of the business? Because it seems to be yo-yoing.
So good question, Mike. So the budget, I mean, you'd expect me to say this, the budget is correct because we've not taken any funding out because of the level of vacancies in previous years, and it's matched to the level of income we've got. And indeed, 2 years ago, we actually invested just shy of £1 million in the division for safer staffing as part of our financial plan. So I think, you know, we've got some pressures in there, and that's part of the recovery plan at the moment about how we can manage those and bring that. I'm going to be completely honest with the board. Bring that overspend down this year, but focus on what the exit rate is for this year going into 25-26.
Thank you. Thanks, Mike. Thanks, Pete. Any other questions? I can't see any other questions. Is board happy to approve the finance report?
It should just be to note. It should be just to note.
Sorry,
it should be to note, Caroline.
It should. No, I've got yes.
Apologies.
Yes, it's all right. It's just to test me, isn't it, Pete? You know, I've got one thing on the paper and one thing on the agenda. Thank you for that. So just to note, everyone happy? Right, okay. Right, moving then on to the performance report, please.
So again, I'll be very brief. This is the performance report at the end of Q1, Chair, and it very much reflects the continuing trend in performance that we saw in previous years. We continue to see strong performance on our workforce metrics and our clinical supervision, and we know waiting times continues to be an area of focus for us. And you can see within the front sheet of the report, there's ongoing dialogue with the ICB on potential solutions, but obviously that is dependent on the wider ICB financial position priorities as well. Hilary mentioned earlier today that we've had a focus on sickness, so we've asked for a focus on sickness in relation to safer staffing dashboard. And we did have a conversation on the virtual ward earlier, didn't we? And you can see in the performance report, occupancy is up to 50% now in the performance report and on an upward trajectory. So again, I'll be brief because of time. Happy to take any questions from me or my colleagues.
Are there any questions? Mike, is that a legacy hand, Mike? Yeah. Okay, Francis. And then Stuart.
Yeah, I was just going to say, we used to get, on our lost track, an additional attachment to the back of this on waiting times, quite a detailed breakdown on waiting times. And I've lost track of why that's no longer with us and whether we should still have it. I just wondered if Lynn wanted to give us an update on that, because it was really useful, detailed analysis previously.
Lynn?
Yes, that report, Francis, is prepared quarterly and it goes to the executive management team. It is scrutinised there, and obviously what appears on the cover sheet is just obviously a summary detail from that. Also, I do take a detailed report for board. To the quality committee as well, Caroline.
Yeah, but it was very helpful for board to have a sort of précis of that. A little bit. I can't remember that coming off, being agreed to come off for board. Maybe I'm wrong. Can we look into that outside of the meeting, because it was a really helpful addition? Yeah?
Yeah.
Okay, fine. Thank you. Any other questions, Stuart?
Yeah, I'm conscious of the time, but this is an important element of our work, isn't it? Just looking at the performance. Lynn, you and I had a little bit of an email exchange yesterday and today about some of the continuing rising trends in number of patients waiting for various lengths of time. For example, adult ADHD. Do you want to just comment on what you replied to me on those trends, which are kind of looking intractable at the moment? Yeah.
So the only area where we've got increasing waiting times over 52 weeks are neurodiversity, as the graphs show, Stuart. So adult ADHD, children's ASD and children's ADHD. Yes. So as the board know, we were able to invest non-recurrently last year. And that obviously supported us immensely in reducing waiting times, particularly in ASD for children, but actually across the board in those neurodiversity waiting times. That non-recurrent funding ceased at the end of March this year. We've had ongoing conversations with our ICB, ICB board level and at place level around ways forward with that. We've put a number of different proposals together as to how we can expedite waiting times, but obviously there is a cost given the exponential rise in demand. Adult ADHD is an interesting one. The actual demand has risen twice as much, in fact, more than 2 times the amount that we were seeing before COVID. So we've got a commissioned capacity that just does not reach the demand, unfortunately. So, and that's why the board will be aware that in terms of the over 52-week wait risks on our risk register, the neurodiversity risk is separated now from the rest of the over 52-week position, because actually that's coming down and we're making really good progress. It is just these neuro waiting times that are really challenging for us. There is work still taking place across the system. We are looking at alternate models. We're participating in all of that work. We are looking at other areas as well. We're not an outlier. This is a national issue and a national trend as well, but systemically, as we've had conversations here before, we certainly need to do something very differently around the children's position, because what we are starting to see is pressure on our core CAMHS service now, because those children that are waiting obviously are more likely to experience other mental health impacts of that wait, which is, really disappointing for all of us. It's not where we want to be, but we are still, working hard with our commissioning colleagues to find a way forward with this. Just on the adult ADHD, we've temporarily closed the waiting list to new referrals because we just know our wait is, it's longer than we would want to have anybody tolerate. That means that we're working with the place colleagues, we're writing to those service users, we're advising that they can, if they wish, not wait with us and choose the right to choose option, which is another provider. So we're going through that process at the moment, but I think quite frankly, it's not where any of us, I'm sure where the board would want us to be, but operationally we are doing everything that we can. We continue to examine our capacity to make sure that that's optimized as well. So the resource that we do have is delivering us, the efficiency that you would expect us to. So we undertake that capacity demand analysis really regularly.
Thanks, and it's definitely not where we want to be, but I want to sort of be explicit about the choices reasons we're having to make and the actions we're taking to essentially tolerate what is for us not great performance, not we want to be there permanently. It changes our risk appetite. We're accepting things that we wouldn't want to accept ideally. Thanks for pulling that out.
Thank you. Mike?
Sorry, is
it a legacy hand?
It must be, but
don't worry.
It's just kicked me out, and I've come back in again, so I'll sort it.
Okay, thank you. Can I just ask be passed on? I was reading just earlier this week that NICE have approved an ADHD digital observation test for 6 to 17-year-olds, which apparently is computer-based and is going to help speed up assessments. Is that something we're using or looking to incorporate, Lynn?
Yes, we're already using that to some degree, but we are constantly look at that NICE guidance, Caroline. So absolutely, yes.
Thank you. Thank you for that. Appreciate it. Okay, right. No other questions, so we'll move on. Thank you both, Pete and Lynn. Review of the Constitution. I don't think there's anything really to say on this because there's nothing we're changing or proposing to change. And the Council of Governors have had the same conversation at the Council of Governors the other week. So comments, please, before we move on that. No? Okay, let's move on then. And we go straight to the Finance and Investment Committee Assurance Reports. Francis.
Thanks, Chair. There's two here because the one in May was late in May so that we could do the year-end review. So it missed the previous board by a week. I won't put a huge amount out of that other than to say, as we already know, that we hit our plan for last year, which was excellent and delivered a very strong cash position. And it's a credit to the team for all of the hard work that they had put in there. And at that meeting, we did pick up on what Peter's spoken about today about the agency spend and what we will need to do with that. And we also, at that point, picked up on the stretch target for the ICS, which we thought was quite an ask from their perspective. In terms of the more recent one, which was only on Thursday, this now looks at where we are so far this year. And as Pete said, we got good assurance that the trust is on plan. We had a look at controls around payments over £10,000, showing the good governance we've got in terms of our expenditure. Our BRS is on plan, and as we know, was complemented in our recent board-to-board with the ICS and the way that we go about that. And again, credits the team for that. The estate plan, we reviewed that, and it's delivered against its objectives to date and is being put together for a new estate plan looking forward. And the same with the green plan, we had a look at that, and it's delivered against all of its objectives. A few areas that we were worried about, which might picked up a little earlier, the financial pressures within divisions, particularly the mental health. But the good news is not only do we have a recovery plan, but it's being QIA'd, which you'd expect to make sure we're not affecting patient safety and patient outcomes, which is great. And we recommended to the Workforce Committee that they took a deep dive on agency spend to look at it from a slightly different perspective rather than a financial perspective. So we suggested that, and we recommended a review of the wording on the risk around the ICB finances. And we also have attached here, because we missed the May meeting, the effectiveness review for the committee and the recommended new terms of reference, which have had some slight tweaks with us taking on digital, cyber, etc., and the green agenda. So that's my report, Chair.
Thanks very much on that. And can I just say, I thought how the Trust responded to the CrowdStrike was really good. I think it really tested our resilience situation, and appreciate everyone involved in that too. Any questions to Francis? No, thank you. We'll move on to Dean for Workforce.
Yeah, thanks very much. This was an additional committee meeting to approve some reports, some of which we've seen on the board here today coming through, and we also approved the workforce plan, which is again part of the ICB planning requirements as well.
Any questions to Dean? No, thank you very much. Stuart?
Thank you. This from our June meeting on the Specialist Provider Collaborative. A couple of things, just we heard positive news about innovations again. The EDIT team, eating disorders in team, having a positive impact. We got an update on contract negotiations, which we'll come to in our meeting this afternoon. And I just want to refer again to that piece of work that's in hand, which is about identifying patients and service users clinically ready for discharge or to the next phase. Holding them in their current situation costs a £10 million bill, and if we want to move each of them to their next lower cost venue, then we're going to save money. And it's a piece of work we need to do at a system level, because it's a great example of identifying allocative efficiency. And on that was all good to see, good work in progress. There's still stuff to be done there. And on the downside, we're just keeping an eye on the financial pressures to do with CAMS, the complexity of CAMS patients, still containable with their overall contract value, but we're keeping an eye on that particular financial risk, and we'll continue to do so. That's it from me. Thank you.
Thanks, Stuart. Any questions to Stuart? No? Okay, thank you very much. We move on to Phil and quality.
Yeah, thanks very much. We just need to probably just double check the board work plan to make sure that we have a slot, because we have 5 quality committee meetings, and it wasn't on the agenda this time. So, but we've got the papers. It's a good meeting. The physical health policy will be sent to the next quality committee meeting, and I'm making this part of my PDP to just check that the trust not just got a good policy, but it's actually making a difference to the health of people with learning difficulties and their severe mental health problems. And we're also looking at a report to come to quality committee about the quality impact, if any, of the budget reduction schemes. In the meeting itself, we had a presentation on the progress of the CQC recommendations on Humber Primary Care. 2 out of the 4 recommendations had been met, and we were waiting on whether a new telephone system. So I don't know whether that's actually in yet or not. But overall, good meeting, and we're meeting again in a few weeks' time to go through some of the annual reports.
Any questions to Phil? I noticed in the National GP survey, there's more work needed at Humber Primary Care in terms of the outcomes on that, which may be picked up already, but yeah. Presumably the quality committee is looking at some of those survey results as well.
Absolutely, and yeah, no, I think it's important, and there has been issues, particularly at Humber Primary Care, and we're looking at those closely.
Okay, right. No other questions. Thank you very much, Bill. That brings us to the end of our formal items. There's any items to escalate? I haven't been forewarned of any. No. Any other urgent business? I haven't been told of that. No. Review of meeting. I think there was probably quite a few points that came up during the meeting on different items that we just need to make sure we capture and they're full progress appropriately. We had to include, as you know, we missed out on having some of these reports at our meeting before because of the general election. So it's always going to be a full meeting today. So I appreciate everybody's patience with that. Any other comments? Great. Okay, fine. In that case, I'll close this meeting and I suggest we come back at 1 o'clock for part 2 and have half an hour break. Okay, is everyone happy with that? Perfect.
Thank you.
Thank you, everybody.